a privilege.
Yeah.
We share the privilege and the honor. Thank you.
Thank you. So, is it 4 o'clock?
I am making you live.
Just 1 minute.
हो गया. Boss.
1 minute.
Let boss.
Wait.
Yes.
Pachori boss, आप start करो.
You just
Then over.
Mr. Verma will start, then me, and then Paramita want to say something.
Then I will introduce.
Yes. That's
Quickly. थोड़ा fast करना है. 2 minute में हो जाए ना. Fast.
Yes, it will be done.
Okay.
No problem, because even the people just look at it, take 5 or 6 minutes for them also.
Okay, it is 4 o'clock, boss. We can start.
Yeah. Yes, sir.
Dinesh, can you see the screen?
Yeah, I can see, sir. You can start.
I mean, Mr. Verma will say something.
Yeah. Yeah, good evening everyone. And I deem it to be a pleasure to be at your midst. I deem it to be a pleasure at your midst in this very fine evening, and welcoming you all for this webinar. We are conducting, it is the 5th of series with Dr. Satish Jain, Explore the Legends. And we had done our live webinars, live surgeries in the past. And this is going to be a very exciting session today. And today, a very, very heartiest welcome to Dr. from France. Sir, heartiest welcome to you, sir. And we have one more guest today, Dr. Narayan Jaishankar from Mumbai. And with our existing team, Dr. Satish Jain will be leading the team, along with Dr. Rajiv Pachori and Dr. Parmita. Again, once again, my heartiest welcome to you on behalf of Sun Pharma. This is Mahendra Verman, DGM Sun Pharma. Just 1 minute, I will hand over to Mr. Amrish Sahai.
Thank you, Mr. Mahinder. Very good evening to everybody for joining us today. Indeed, thankful to the beautiful families who have spared you with us for this evening. In fact, with this all era of uncertainty of COVID-19, we believe with faith and optimism we shall overcome this scenario very soon. My name is Amrish Sahai, and on behalf of Sun Pharma, today I feel privileged and honored to welcome our eminent speakers and all the viewers. I'm sure last 5 series of this webinar, everybody must have gained by leaps and bounds. I'm sure it is going to be of immense value for each one of us. With this, I hand over the session to Dr. Rajiv Pachori, sir. Over to you, Dr. Rajiv.
Good evening, all my friends. Namaskar, all my countrymen from all abroad and the dear friends from all around the globe, actually. So again, this is the 5th seminar, or you can say episode, or this of this series of ENT. First 3 were on the chronology, then 4th one on the temporal dissection. Today is the one of the biggest surgery of ENT, that is Glomus Jugulare, where we can see the ear, we can see the neck, we can see the skull base, we can see all the things on the ear, and we will see all the dissections from the wonderful man, Dr. Satish Jain. And again, I would like to thank you all again for joining us. And we have 6 to 7 more webinars to come. So please be with us, enjoy. You are all free to communicate with all of us by questions, you can message us, you can write us, you can to YouTube through this link. So again, enjoy today, next 4, 5, 6 hours, and thank you again, all of you. I think Dr. Paramita want to say something. Dr. Paramita, to you.
Yes, welcome, heartiest welcome to one and all. So as we've seen that how Dr. Satish Jain has simplified chronic rhinosinusitis in our previous webinars. So similarly, when we hear it's a case of glomus, most of us get nervous. So I think after this session, the entire concepts of dealing with the glomus tumor will be simplified to all of us. And from my side, it's a request to all the audiences who are watching, who are asking questions. Please make sure your questions are related to the steps which are going on the screen, which gets easier to ask. And the other questions related, you can ask, we can discuss them once the session is over. So, heartiest welcome to Professor Mannion from France and as well as Narayan Jaishankar, sir. So, without any delay, I think we'll move on to Dr. Satish Jain, sir.
Thank you, Paramita. Can you hear me?
Yeah, we can hear you.
So, good afternoon, everybody. It's a pleasure to welcome you again to this session of the webinar from the Sun Pharma. And I'm indeed grateful to the team Sun Pharma for this wholehearted support of organizing such events. Thank you so much for being with us. And today is a great day for us to have a person whom I call phenomenal. He's like a father figure to us in this science of lateral skull-base surgery, Professor Magnan from France. And we all know, we have been hearing him for a lot of times for different things. He has conducted several workshops in our country, and he is like one whom if I am not wrong, is in the Guinness book. It is supposed to be for the number of cases he has done for the posterior fossa endoscopy. He is the pioneer for that surgery. He has extensive experience of more than 40 years in the science of lateral skull-base surgery. He is presently associated as an emeritus professor of Aix-Marseille University in France. You know, for all, he is honorary president of European Academy of Otology and Neurotology. He has been the past president of prestigious Polyester Society. We all know in otology what the Polyester Society means. And his huge interest and work in research and teaching in cholesteatoma, vertigo and skull-base surgery. And being associated with Professor Mario Sana, who is another phenomena, and they have discovered so many new procedures, new guidelines to treat complex lateral skull-base pathologies. So, sir, we from India welcome you from our bottom of our heart to be part of this session, and believe me, every possible person who has been attending will be surely benefited with your experience, your comments, your suggestions. Thank you so much once again, sir, for being with us. Thank you.
Thanks to you. Very kind word. Thank you very much.
Thank you. And today,
I am not as a professor, but as a friend.
Thank you, sir. Thank you. You have always been treating us like that. Thank you so much. And more than that, we have our dear friend, who is again a very committed skull-base surgeon. He is not limited to the lateral skull base, but he is 360-degree skull-base surgeon. Our own, one of the most decent guys you can think of, Dr. Narayan Jaishankar from Mumbai. And he is associated with
Nanavati and yeah.
Greatly benefited with your presence. Thank you.
Thank you, sir. Thank you, sir. Pleasure to be here.
So, and before we start, again, I would like to thank the person who is behind this show, Dr. Rajiv Pachori, who has put in so much of hard work in organizing this event, and Paramita, as usual, doing her best to make the event successful. Thank you so much. So, now we move on to the subject that today, what it is designated for. We are dealing with a complex pathology. For reasons I will tell you. This patient, I tell you what we are operating today. And last time we discussed the anatomy of the temporal bone in detail. And I threw some light on the anatomy of the jugular foramen. This guy is a 30-year-old male patient who had complaints of tinnitus on the right ear as well as hearing loss. That was the only complaints. No pain, nothing. That's how these tumors present so varied. And he, after consulting so many doctors, finally, when the scan was done, turned out to be having a tumor in the jugular foramen. That's how he came to us. Now, before going to the clinical details of this patient, this pathology, you know, tinnitus, hearing loss, and a tumor in the jugular foramen all point out to a single lesion. We all know that's a very common one. commonly known as glomus jugulare, though this terminology is not now being replaced by a more acceptable terminology, that is paraganglioma. Paraganglioma are very tumor occurring everywhere in the body, and they are divided into sympathetic and parasympathetic, and our head and neck tumors belong to the parasympathetic, which rarely secrete. So this patient presented with simply with a tinnitus and hearing loss, nothing else. Let me put you some slide to show you how this happens. Can you connect my laptop? Connected?
Yeah.
Are you getting the picture?
Yeah, we are getting.
See, this is to show you, this is an schematic diagram, how this tumor arises, how it spreads, and how the symptomatology varies. So, for the example, this is the jugular vein, which forms the jugular bulb and then the sigmoid sinus on this side. And this is the internal carotid artery where it enters the temporal bone and turns anteriorly as a vertical segment first, then genu, and then horizontal segment. And the sinus turns posteriorly after the jugular bulb. This area at the dome of the, in the adventitia of the dome of the jugular bulb are the paraganglionic cells where this tumor arises, this jugulare. These are glomus body, that's why earlier it is used to be commonly known as glomus jugulare. I mean, on our tongue it still comes popularly as a glomus jugulare, but it is arising from the paraganglion cells from this area. Now, how the symptomatology varies? From where the tumor goes, which side, accordingly the patient presents. Like for example, this tumor commonly, after growing, starting from here, it goes up in the hypotympanon. Hypotympanon is above. The middle ear is above. If it goes in the hypotympanon, as it grows, it presents with a conductive hearing loss. Lateral to this jugular bulb is the tympanic bone. Very commonly this tumor goes laterally and erodes the tympanic bone and present in the external auditory canal, and we commonly call it as a rising some appearance, some mass in the external auditory canal. By going into the middle ear, by disturbing the aeration system, it may present with a discharging ear, and it's not uncommon to see many a time this tumor, which has been diagnosed as a surprise findings in patients who are taken up for CSOM surgery as they present with discharging ear. We have seen couple of cases referred to us who were earlier opened by the surgeons as discharging ear, and finally they came across a vascular lesion and they abandoned, and it turned out to be a paraganglioma. That is how they commonly present. Similarly, we all know, we saw in the dissection last time, the facial nerve crosses the jugular bulb. So as this tumor grows laterally, it may involve the facial nerve, and in a chunk of patients, up to 20% of the patient may present with facial palsy. Up to 10% of the patient may remain asymptomatic in the beginning, even if the facial nerve is involved, and that is so pity for the surgeon. Patient coming to you with a good normal facial nerve function, and the facial nerve is involved by the tumor inside, and when you explore, you find the facial nerve totally involved and you have to sacrifice it. Which one? Which was a previously normal functioning facial nerve. That happens in 5 to 10% of the patient. So wherever the tumor grows, accordingly the patient present. Now surprisingly, we have some presentation which are unbelievable. Like we all know, this jugular foramen is the area through which a lot of cranial nerve passes from the cranial cavity outside into the neck. Like 9th, 10th, 11th, 12th cranial nerves, 9th, 10th, 11th through the jugular foramen, and the 12th to the hypoglossal canal deep to jugular foramen. Now, as I said, as these tumors grow, many a time the tumor start compressing the cranial nerve, and that remains the only presenting symptom. And many a times you have got the patient who presented with only unilateral vagal palsy, unilateral vocal cord palsy, which on the entire imaging of the head and neck turned out to be having a tumor in the jugular foramen. So that's why it has been a traditional teaching that all cases of unilateral vagal palsy or vocal cord palsy should be evaluated for skull-based imaging to rule out all these lesions. We have number of cases who presented with single unilateral vocal cord palsy. Similarly, these tumors, as they grow in the middle ear, they pass into the eustachian tube preferentially, and they may present into the nasopharynx. We have, in my series of now around 200 cases, two patients presented with a oral bleeding, bleeding from the mouth. When we put the tongue depressor, we saw some mass coming out from behind the soft palate. And since it was a bleeding issue, we got the scan done and it was a paraganglioma, which was coming from the jugular foramen down the eustachian tube in the nasopharynx and then hanging down in the oropharynx. That's how they have their varied presentation. So we need to understand this anatomy of the jugular foramen, we all know, is very complex due to all these neurovascular structures and the connection in the surrounding. That's how these patients present so varied. And accordingly, we all know these are vascular tumors. So accordingly, they acquire vascularity. See, when these tumors are limited to jugular foramen, they acquire blood supply from the ascending pharyngeal artery. As these tumors grow behind into the mastoid, suppose they go behind to the mastoid, they acquire additional blood supply from either occipital or this posterior auricular artery. If they grow posterior inferiorly towards the condyle and they go out in the neck towards the vertebral artery, they acquire additional blood supply from there. As they go up towards the aortic and anterior-superiorly, they acquire additional blood supply from the middle meningeal artery branches. So according to the tumor spread, you can gauge the idea that where they are getting their blood supply from. Though the final answer is, for the vascularity, we need to have a good angiogram to know how these tumors are supplied by various vessels, because that has a strong implication on the management of this tumor. So the whole idea is diagnosis, and symptomatology can be varied according to the tumor extent where it is going to, and accordingly they present. And then finally, once you are in suspicion, the next way is to get imaging done, because imaging, they have certain characteristic features on the imaging by means of which their diagnosis is confirmed. The reason is these are vascular tumor, deep-seated tumors, so they are never biopsied for the diagnosis. The reason is so obvious, like angiofibromas, and because of the characteristic imaging features, we need to rely on the imaging for the diagnosis. So for this particular patient, if you go to what kind of imaging he came to us at the time of presentation, let me show you. First of all, are you getting this CT scan picture?
Yeah, very good. No problem.
The moment I describe this diagnosis and imaging part, we'll take the questions together, and we'll have Professor Magnan's and Dr. Narayan's opinion as well on this issue, and we'll take all questions. So first of all, this was the scan with which this patient presented to us. This is a simple non-contrast CT scan. Again, when you are suspecting a tumor, a non-contrast CT scan is never sufficient, because a non-contrast cannot differentiate the tumors from other inflammatory pathologies. So ideally it should have been, what you should have been ordered is a contrast CT scan. Anyway, what we get here is a non-contrast CT scan, and if I go from above downwards, I am going from above downwards. See, this is the right side, this is the normal left side, and what we observed, when we go down, see, this is the level of the intra-auditory meatus, that is the level of the cochlea and the vestibule and the semicircular canal, that is the horizontal petrous carotid artery coming. I am going further down the cochlea. Now nothing has been appreciated so far. It looks like a normal CT scan. If you compare even with the normal side, all this is normal with normal pneumatization of the mastoid. Now as you go down, now see what is happening. The jugular foramen is coming into the picture, and now see what is happening. See the jugular foramen compared to the opposite side. Can you see?
Yeah, very clear.
And see this jugular foramen, which is enlarged, looks like moth-eaten appearance, and some soft tissue opacity which is extending laterally into the mastoid, which is extending laterally into the extra-auditory canal. Can you appreciate this? And this is how these tumors expand. See this entire enlargement of the jugular foramen with extension into the mastoid and the extra-auditory canal, and this is a non-contrast CT scan. So to further evaluate, now if we see in the three-dimensional plane, let me put up in the three-dimensional plane, on the axial, to see where the jugular foramen is. See where the jugular foramen is on the coronal and the other pictures. Now, Now see on this side on the coronal. Yeah. This side on the coronal and this side on the coronal. This is non-contrast, so you can't appreciate much. But what we see this opacity in the region of the jugular foramen. Now looking at all these features, we ordered a contrast CT scan. And for that, let me show you. And that is, we got a not only CT scan but a CT angiogram. Now, once you have a doubt clinically that it is a paraganglioma arising from the jugular foramen, you have clinical otoscopic signs of a reddish mass with a pulsatile finding in that. So the clinical diagnosis was very obvious of a paraganglioma. So we directly ordered the CT angiogram for two reasons. First of all is a contrast showing the entire tumor with any bone dissection going on. And second is to know the feeders going to the tumor so that we can tackle them intraoperatively. We can take a call of if you are getting embolization done, you can have a good idea of having the need of the embolization and the quality or type of embolization you are going to do. And third is to know the idea of the cross circulation at the level of the circle of Willis, because these tumors, I will show, have a propensity to involve the carotid artery anteriorly. And in that situation, once you deal with the carotid artery for any tumor in the skull base, you need to have a full information about the circulation at the level of circle of Willis so that you don't result into a disaster in case the carotid artery is unfortunately injured. So, what we get out of this, let me show you first, go to the temporal region. This is a CT angiogram, so it has a contrast CT as well. Now, let me show you. Yes. See now, this is the normal side on this. Can you see? Hello?
Yeah, yeah.
And this is the side on this side. This is the region of the jugular foramen, which is so expanded. Can you see?
Very clear.
So now what we need to know from this CT scan, what we expect. Number one, the bone dissection. See, this tumor is already coming into the mastoid laterally, and lateral to this tumor is the vertical portion of the facial nerve, which is commonly involved by this tumor. The part of the facial nerve which is most commonly involved by the tumor is, which is closest to it, lateral to it, is the vertical segment of the facial nerve. So this is the jugular foramen, this is the tumor in the mastoid, and this is the level of the facial nerve which is lateral to the tumor. Very, I would say it's not uncommon to see this tumor invading the facial nerve and presenting with facial palsy, as I have already mentioned. Now, what second information we want to know from this CT angiogram? I mentioned in the radiology talk that day in the sinuses that once it comes to a CT angiogram, we cannot rely on the radiologist's report that what vessels are supplying. We need information not only what vessels are supplying, we need information how they are entering into the tumor so that we can plan catching them, those vessels intraoperatively. That's how this strategy of reading the CT angiogram ourselves has made us doing this tumor even without embolization. Or majority of the paragangliomas, so jugular paragangliomas, we are doing without embolization. The reason is by means of CT angiogram, by interpreting this on ourselves, we plan how to catch what all vessels which are entering into the tumor at what level. And this is what in next 2 minutes I will take you through how the CT angiogram is so reliable. Now, look at this. You can easily read this. Can you see the carotid artery on this side and this side?
Yeah, yeah, very clear.
This is the arterial phase. We have venous phase as well. Both arterial and venous phase are required. I'll tell you the reasons. So number one, this is the common carotid on this side, common carotid on this side, and this is the jugular vein on this side, and this is the jugular vein on this side. Can you see the difference in the jugular vein on both sides?
Yes.
Can you see the difference? Why it is?
Yeah.
Because of the stagnant blood. There is no blood flowing in the jugular vein because of the complete blockage at the level of the sigmoid sign, the jugular bulb. So there is no flow. Anyway, let's go up. Now I am going up. See, look, keep an eye on the common carotid artery only. Is the picture clear?
Yes,
Yeah,
yes.
very clear.
See, my cursor is right on the common carotid artery. I don't believe on following the radiologist's report here for the reason it's not that radiologists are wrong. The reason is I want the clinical information how these vessels are entering into the tumor so that I can plan catching them intraoperatively. So this is the cursor is on the common carotid. Now see quickly as I am going up, the common carotid is going to bifurcate into two vessels. Can you see very clear? Can you see very clear?
Yes, sir.
The external carotid and the internal carotid. Okay?
Yes.
Now we all know the internal carotid doesn't give any branch in the neck. Agreed?
Yes.
So now let me follow the external carotid here. See now the branch arising from the external carotid. Can you see this?
Yes, sir.
See this external carotid? And now see the branch arising from the external carotid here. Follow this branch. Follow this branch. This, I am just keeping an eye on this branch. We'll follow each and every branch. See this branch, where it is going? This is lingual artery.
Okay.
Can you see very clear?
Yes, sir.
Is that clear or not?
Yes,
very
sir.
clear.
Yes.
Now follow, now coming back to the external carotid again. Follow the other branch, this other branch where my cursor is. See this is the first branch where my cursor is. Now lingual is going anteriorly. And so this is ascending pharyngeal dividing into two vessels here. See this? This is ascending pharyngeal, my cursor, where my cursor is. Let me go up again. This is the vessel ascending pharyngeal. Can you see again?
Yes.
And follow this. This is the facial artery which is arising from the external carotid, going lateral to the mandible. Furthermore that, this external carotid is moving behind itself. And see the two major branches. Can you see these two major branches entering into the tumor? This is the cervical part of the tumor where these two major vessels entering into it. Can you see very clear? This one and this one, two huge vessels entering into the tumor. These are the vessels which are the major vascularity of the tumor. See, this is my internal carotid now. This is the this is the tumor here. And see, this is a huge tumor which is extracranial. This is extratemporal, still extratemporal. See my master process here coming into the picture?
Very clear.
And now see, this huge tumor which is continuing above into the temporal bone. See now it is the level of the jugular foramen. Can you see very clear?
Yes,
Very clear.
Now I am going back again. What is this in the anterior relationship of the tumor? That is carotid artery. See, I am going back in the neck again. See in the neck, keep an eye on the internal carotid. Can you see here? Follow the internal carotid, follow the internal carotid, follow the internal carotid. See my cursor and see the entire tumor which is behind the internal carotid. And see, as you come in the jugular foramen, the internal carotid is involved by the tumor from behind. That is how they commonly involve the posterior wall of the internal carotid. They involve the periosteum very often. There is no bone between the tumor and the carotid here. See on the opposite side, this is the carotid. Can you see here? That's the jugular foramen. And this is the bone, the carotico-jugular spine which is intact. On the opposite side, this spine is completely eroded. The jugular foramen is expanded. And the carotid is in the anterior part of this tumor which is completely almost more than 180 degree involving the carotid artery. Can you see very clear?
Yes.
This tumor is engulfing more than 180 degree carotid, vertical petrous carotid at this level. This is vertical petrous carotid. Now if I go up now, see, I am going up now, keeping an eye on the vertical petrous carotid here where my cursor is. Now it is becoming horizontal. Can you see this here? See the horizontal petrous carotid. This is cochlea and it is absolutely free. There is no tumor over it. So if I go from above downwards, that is the genu of the carotid, and from the genu level down, this tumor is involving the carotid from behind. That is very, very clear, and that has a most significant impact on selection of surgical approach to handle these tumors. The reason is to handle such jugular foramen tumor with this much of the vertical petrous carotid involvement. We discussed that day during temporal bone dissection how the facial nerve was crossing the jugular foramen. Now for limited involvement of jugular foramen, tumors having limited involvement of the jugular foramen, you can go by conservative approach to the facial nerve. By staying anterior, posterior, medial to the facial nerve, you can remove those tumors which are not involving extensively the carotid artery. But this much of the vertical petrous carotid involvement, this is more than 180-degree involvement of the vertical petrous carotid here. You cannot afford to go by narrow corridors. Without shifting the facial nerve from this place, that is the hallmark of this approach which we are going to use today, the infratemporal fossa approach. So without having the facial nerve out from that place, dealing with such a vascular tumor, invading the carotid artery so extensively, it's a disaster if you're trying to approach like this. Either you will leave the tumor behind at the end of the surgery, and if you are trying to get the entire tumor out, you may end up damaging the carotid artery because you have no control over the carotid through that narrow corridor. Those narrow corridors are important for limited lesions. They are very initially popularized by the Jackler from San Francisco, where they devised this intact bridge approach, infralabyrinthine approach, retrolabyrinthine approach to the jugular foramen region. But those are important for limited involvement of the jugular foramen, tumors like those, and non-vascular tumors like, suppose if it is a schwannoma, you don't have to go so radical to the facial nerve in schwannoma, those who are not so vascular, those who do not invade the carotid artery like these glomus. So glomus, these paragangliomas, though they are benign, but they are locally aggressive. They erode or invade whatever structure they come in contact with. Maybe bone, maybe soft tissue, maybe artery, nerves, they can erode anything coming into contact. That's how these tumors expand. So the information what we got, second information we got out of the CT angiogram is, first is the bone erosion, the carotid canal erosion, the mastoid erosion, extension into the extraordinary canal, then the vessels, these two big vessels arising from the external carotid which will catch intraoperatively. We have not embolized this patient. Majority of the patient we don't embolize. I'll come to that point why we are not embolizing. I am not against embolization. Embolization is a fantastic thing, provided if you have a good intervention radiologist and get embolized with the experienced one to the micro level, microvasculature level. It's not that you block the parent vessel, it is going to work. It is not end artery. The embolization should reach the microvasculature level, and there are number of advancements we'll discuss during surgery on the embolization which we can take the advantage of. Secondly, the cost involved. Third is the dangerous anastomosis, which sometimes with the vertebral artery or internal carotid, if you are not careful, can lead to complications. So embolization is not always safe as well, and cost in India sometimes is more than the cost of the tumor surgery. So looking at all the aspects and looking at the CT angiogram finding, we devise our approach to catch the vessel intraoperatively supplying to the tumor to devascularize and leading to a situation of intra-op embolization, you can say. And you'll see in this patient, we have not embolized. The kind of blood loss you will finally realize as compared to the embolized patient is comparable overall. So surgical technique has a lot of bearing on the overall bloodless. It's not embolization alone. Embolization doesn't mean the entire field is bloodless and you will not have any bleeding. It has a significant impact which can reduce. It doesn't mean there is no bleeding at all. So the third investigation after that we got this, one more information out of this.
So the erosion of this carotid-jugular crest or spine is the Phelps sign.
Yes, that is a sign of jugular paraganglioma. See, the other paraganglioma, I am coming after this on the classification. The other paraganglioma is a tympanic paraganglioma. See, these paragangliomas are arising from the paraganglionic cells distributed in the temporal bone. Those along the Jacobson's nerve are tympanic paraganglioma. Those on the dominum of the jugular bulb are jugular paraganglioma. So accordingly they have their extension. So now the third information from CT angiogram, again it is very useful. See this, the carotid artery. We saw this is horizontal petrous. Can you see this?
Yes, sir.
As I go up, it has become at the level of the foramen lacerum. As I go up, see this is cavernous. See this cavernous carotid? This is supraclinoid and this is subarachnoid segment of the carotid. Now here it divides into two portions. See this? This is anterior cerebral joining the opposite anterior cerebral, very clear?
Yes, sir.
This is anterior anastomosis, and this is the middle cerebral, which is the main vessel to this region in the sylvian fissure. Secondly, go down. This is the word basilar artery in the posterior canal fossa. Can you see this?
Yes, sir.
If I follow the basilar up, see it is dividing into two posterior cerebrals. Can you see? And one of the carotid branch, see this, this is posterior communicating artery. See this? Posterior communicating artery on both sides. See this? Joining the carotid artery.
Yes.
Can you see this? So
Yes.
this gives a good idea of a cross circulation with good patent anterior and posterior communicating artery on both sides, which can give you a fairly good idea of a cross circulation. But this is not gold standard. For the cross circulation study, the gold standard is digital subsection angiography. But this patient, with your experience with posterior part of the vertical petrous carotid involved, you can manage with your experience. So that's why we didn't get a digital subsection angiography done in this particular patient. Yes, in extensive involvement of the carotid, that is the requirement. The digital subsection angiography, there are many ways. There are hundreds of ways mentioned in the literature regarding the parameters to give you an idea of a safe carotid resection. Giving you an idea that you can resect the carotid without a stroke. But none of them is 100%. If you abruptly close a carotid, abruptly, the chances of stroke are almost 25%. But with taking into consideration all these tests suggesting you about a good idea about the cross circulation, you can minimize it. And what we take into consideration at this point of time, I would always emphasize, we take into consideration three parameters. Number one, we do a balloon occlusion test under hypotensive condition, not normotensive condition. Under hypotensive condition, to give you a good idea, if the patient passes that for 45 minutes under hypotensive condition, you can have a fairly good idea that he can pass a carotid occlusion. Number second test we take into consideration is the venous phase difference on both sides. Venous phase difference is what? Difference in the distal cortical vein filling of the distal cortical veins. If the difference on two sides after occlusion on one side, if it is not more than 2 seconds, that means the cross flow is supposed to be good. If it is more than 4 seconds, you cannot consider that. That means your cross flow is not good and you cannot take the carotid into resection planning. You need to do something like a bypass or a stenting or something as the cross flow is not good. And the third parameter, what we take into consideration during DSA, pass a catheter on the opposite side and see the stump pressure. Stump pressure through the closed side, distal to the closed segment. That if that stump pressure of the blood beyond the occlusion site, if it is more than 2/3 of the systolic pressure, it is amazingly good idea that you can sacrifice the carotid without getting a stroke. So whole idea is you need to have a full cross flow studies when you are planning or dealing with a skull-based tumor where the carotid artery is involved. And in that situation, these are the most reliable criteria, but still nothing is 100%. Nothing is 100%, still stroke can happen to occur. That's why all these patients, in spite of all these parameters, and once you sacrifice the carotid, we keep those patients in the intensive care unit with deliberately blood pressure keeping on the higher side with the noradrenaline or whatever by the intensivist to keep the circulation good to the distal cortical vessels. So this is the planning to prevent stroke in the most unfortunate condition a patient may have. Now the third investigation, which has its own value for the reasons I tell you, is the MRI.
Can I interrupt you?
Yes, Narayan. Yes, Narayan.
Satish, we discussed a lot about the carotid resection.
Yeah.
On a more practical level, how often in your series have you considered carotid resection? And if you do, which cases would you consider carotid resection?
Yes, in
Would
Narayan.
you probably leave behind little tumor there, or would you plan carotid resection?
Yes.
What are your thoughts?
In my paraganglioma series, we have done only once. But in head and neck cancers, we have done couple of times. Yeah. And massive head and neck cancers with after the all cross-flow studies and the consent, and we have removed the entire tumor malignancy along with the carotid. We reconstructed the carotid many a times with the saphenous vein. We did a bypass once, not having a very good experience, so we don't look at the bypass much. Stenting, we want to, it has been described by Professor Mario Sana. He has been using for more than 10 years, more than 15 years probably, and with the amazing results. Though we have not done, our cardiothoracic surgeon, they are using stents like anything many a times. So we look up to the stents in the future, and that is something very, very good alternative in those patients who don't have a good cross circulation. And if they are good candidates for stenting, that is a great idea. Stenting is what? Like Professor Mario Sana described, there are nitinol stents available which merge into the intima of the vessel wall. So what you do, you put the stent beyond the area of the carotid sacrifice where the carotid is involved, proximally distally beyond that, and those stents are left in place for 4 to 6 weeks until the neo-intima come to the luminal surface. So when the neo-intima comes to the luminal surface, you can resect the tumor from outside until the shunt wall, and you don't lacerate the carotid artery. That gives you a perfect environment for the radical resection of the tumor. So that is something amazing which has changed the management of these complex tumors invading the carotid artery. Now coming to
Satish, there are a lot of people listening to you.
Yes.
So when would you advocate a carotid resection versus doing a little bit conservative surgery, resecting it, taking off the periosteum over the carotid and trying to take off the tumor? Would you err on the side of caution, or would you go about doing a very aggressive resection of the carotid?
Narayan, that's an amazing question. First of all, that situation which warrants either using a carotid occlusion or carotid resection or stenting, whatever, comes when the tumor invades the carotid artery to the level that the vessel is getting stenosed. It invades the wall of the carotid artery to give irregularities. In post-radiation and post-surgical situation, when the tumor is adherent to the carotid artery, when if you try to remove the tumor from the carotid is not safe, and it doesn't give you at the same time a radical resection. So those patients who pass this cross-flow studies well, after the 3 tests I told you, 3 together, balloon occlusion test under hypotensive conditions, venous flow phase, and the stump pressure to more than 2/3 of the systolic. If they pass these 3 tests together, that is almost certain that they will pass the carotid resection as well. And those are the patients can be taken up for the carotid resection, which gives you the opportunity for a radical resection of the tumor. Only those patients. You can occlude the lumen with the balloons and you can resect. Put the balloons, inflate proximally and distally and resect the carotid along with the tumor. But only those segment of patient. If the cross-flow studies are not good and bypass is not possible, patient is not a good candidate for stenting. If it's a good candidate for stenting, nothing like it. Not a good candidate of stenting, then you have to switch on to either wait and watch, conservation surgery, little bit of surgery, radiation, or whatever adjuvant therapy. Okay? Does that answer your question?
Yes.
So now, moving to the another important modality which gives you another useful information is the MRI. We discussed in the radiology session in the, in the paranasal sinuses, MRI has a great impact now in the skull-base pathology, as it is so versatile. More than 1500 sequences can be done with the MRI, giving different details of the different aspects. So here, what MRI gives, what sequence are to be required. This is a simple T2 weighted sequence. Can you see? The level of the jugular foramen on this side. Now, if I go to the axial section, let me orient you again what we want to see. See on the T2 weighted image in the jugular foramen, with this some flow voids in the tumor, in the jugular foramen at this level, this is the carotid artery here. It gives you a good idea of the carotid artery involvement than the CT scan. So that is classically a tumor at the level of the jugular foramen you can appreciate. But the best sequence you need is a contrast NN sequence, and that gives you complete idea. I will run two contrast sequence together in both planes to give you a full idea of the involvement of this tumor. See this tumor in the jugular foramen region? Is it visible?
Yes, sir.
Now look at the carotid artery. It is the posterior wall of the carotid, almost 180 degree is involved by the tumor. Narayan, can you appreciate?
Absolutely.
And see what is flow whites. See this big vessel. This is carotid, and all these small dots, that is salt, we can call it, is the, yes, salt and paper appearance. The salt is the small flow vessels you can pick up on the MRI as salt, and these are the flow voids, that is high flow vessels. So the MRI gives you a better picture of the involvement of the carotid, number one, the reason to get MRI. Number two, to substantiate your diagnosis. With a classical salt and paper appearance, you can confirm your diagnosis. I told you, we don't biopsy these lesions. The reason is the propensity for hemorrhage and their deep location. So they are always diagnosed on the basis of radiology. Third is, for a differential diagnosis with other lesions of the jugular foramen. By means of CT alone, you cannot. Jugular foramen give rise to other lesions like schwannoma, meningioma, chondrosarcoma. The MRI will have different imaging characteristics using different sequences. Cholesteatomas, like for example in a temporal bone, they are hypotense on T1, hyper and T2, and do not enhance. So if it is a cholesterol granuloma, it will be hyperintense on all sequences but do not enhance. So by means of taking into consideration different sequences together of MRI, we can actually do a differential diagnosis of lesions in the temporal bone. That's why MRI is important. Third reason to get MRI done is the involvement of the neural structures. Suppose, let me show you, suppose the hypoglossal canal is involved. You can have a fairly good idea on the MRI whether the hypoglossal canal is invaded or not. Whether the other nerves or the jugular bulb, see this jugular bulb. This is the sigmoid sinus, can you see here?
Very clear.
And there is no flow in the jugular bulb at all.
Yes, sir.
This has a amazing bearing. This is a huge bearing. Pardon?
Can you compare with the other side?
To the normal.
Yes. See, it has an amazing bearing on the selection of the approach in the decision making. See this? The jugular bulb on this side, see the sigmoid sinus on this side, and it is forming here. You see, this is the jugular bulb, the flow in the jugular bulb, the contrast in the jugular bulb on this side, and you can see very well on the coronal pictures as well. The jugular bulb, sigmoid sinus, all these things to be seen. So the thing which I said, with the jugular bulb doesn't have any flow, it has a huge bearing on the selection of surgical approach, or not only selection, in the decision making. The reason is, if the flow in the jugular bulb is already stopped, that means the collaterals have already developed. Now in this infratemporal fossa approach which we are going to use to resect this tumor, if the blood flow is already stopped in the jugular foramen, there is no flow in the jugular foramen, that means the collaterals have already developed, and resection of the sigmoid sinus jugular bulb will not give any complication in the post-op period, like edema in the brain and high intracranial pressure. Now if the flow continues to the jugular bulb, what happens? If the collaterals are not good on the opposite side, or if it is a dominant side, other side is hypoplastic, it has a huge impact. If you sacrifice that kind of a jugular bulb, with the flow continuing with the opposite side hypoplastic, can be a disaster, can lead to infarction in the brain, venous infarction, because of the high venous stasis in the brain. So knowing the flow in the jugular sinus is very, very important, and you can have a fairly good idea on the MRI again. So second is involvement of the dura and the intracranial structure from anywhere. You can have a perfect idea from MRI, which CT scan cannot give. Mostly these tumors grow intracranially from the medial aspect of the jugular foramen. See, these tumors have a tendency to spread in a particular manner. So the tumor which arises from the lateral aspect of the dome of the jugular bulb, as they grow, they keep on filling the jugular bulb. Once they fill the jugular bulb and go to the medial wall, press on the medial wall, and from there they erode into the posterior canal fossa. They do not enter into the posterior canal fossa from other areas commonly. So if the tumor, whether in the medial wall are the cranial nerves, in the medial wall of the jugular wall are the cranial nerves, what does it mean? If the tumor has not reached the medial wall and the flow is continuing, that means your cranial nerves are intact. Number two, if the tumor has grown through the medial wall into the cranial cavity, what does it mean? That means maybe your cranial nerve functioning pre-operatively good, but removal of that tumor from the intracranial part will result in sacrificing the cranial nerve, and that has to be incorporated in the pre-operative planning, because if it is an elderly patient where you sacrifice the cranial nerve, the aspiration can be a disaster. You can take this chance in a young patient where the cure is primary, and sacrificing the lower canal nerve on one side is not going to be having that much of impact. The compensation will take place with the time in the young patient, which may not take place in the elderly. So age of the patient, involvement of cranial nerve, whether it is going intracranially or not, how the carotid artery is involved, how the facial nerve is related to, how the tumor has gone up in the middle ear, everything has a bearing on selection, decision making, or the selection of the surgical approach. Yes, Narayan, you're saying something.
Satish, you talked about intracranial extensions. Can you also throw light on the fact whether you would touch this intracranial extension? If so, when would you avoid it?
When you touch the
intracranial segment of this
tumor. Okay, when we will address?
Yes.
I follow the philosophy what Professor Magnan follows. We belong to the same school. For that matter, I tell the audience, Narayan has been following the Grupo Pathologico, and Professor Sana Paramita has been to Grupo Pathologico. She has a keen interest in lateral skull base surgery, and we have Professor Magnan here, and we'll have his opinion now on all these issues. So like your question, how will you address the intracranial segment? First of all, why did this question arise? The reason is, you will see in this approach, in the infratemporal approach, we make the neck in continuity with the temporal bone after removal of the base of the skull, the tympanic bone and all those fibrous tissues. So the temporal bone remains in continuity with the neck. Now, if there is any dural defect, you plug with a fat or anything, whatever you plug with, there is nothing to hold below to keep in place, and it may lead to a CSF leak very commonly. So, due to the fear of CSF leak, it is generally advisable, as Professor Mario Sana recommends, we should avoid dealing with large intracranial segments at the same stage. So, by and large in our practice, defects less than 2 centimeters we address at the same stage. Bigger lesions, we always stage the patient, we remove the extracranial part first, and after 3-4 months you can go back. As the skull base is again reconstructed, the chances of CSF leak are over, then you can go by other posterior fossa approach, whatever ports or retrosigmoid, whatever approach you are comfortable with, and you can remove the intracranial segment. And that is the advantage. Another advantage is, since you remove the extracranial segment first, you devascularize the tumor. So once you devascularize the tumor, the bleeding from the intracranial side is less. So this is our philosophy. Professor Magnan, what is your approach in investigation? Do you do something else? I know, my question is why I am asking. In Indian setting, it has been proven that these paragangliomas have a highest, as compared to any tumor in the body, highest genetic predisposition, almost 40%, and genetic testing has become a routine, which is not in our country. So in your setting, are you getting the genetic testing done for all patients?
Regarding your last question, we don't perform genetic tests routinely. It's only when there is a multiple paraganglioma. But when there is only unilateral jugular paraganglioma, we don't perform genetic tests. I would like to make some comment regarding the assessment of jugular tumor.
Yes, we would like to know.
You did a perfect presentation regarding radiology test. But I would like to say, to perform the diagnosis of jugular tumor, we need only CT scan and MRI. We don't need angiography. Angiography is used, and you say that, and you stress this point, only for preoperative assessment. This is the key of the angiography, preoperative assessment. And now, in Europe, when the radiologists are doing angiography, if it is a paraganglioma, they combine immediately embolization. So, in the same state, there is angiography for preoperative assessment of the tumor process and embolization, which is the first step for the operative management. So, it is a teaching session today that you organize brilliantly. I think we have not to exclude embolization. Embolization is very helpful. Help the surgery, we save time, we save bleeding, and this is nice for this very difficult surgery. This was my comment.
Jaldila.
Professor Mani, I want to know what about the catecholamine secretion? Do you even assess that?
Yes, this we systematically assess. We will have to know if there is anesthesia. Ask about that, because they will have to know.
Okay, but not in every case.
No, yes, in every case.
Okay.
We ask about catecholamine. In every case, we don't ask in every case for genetic tests.
And Satish, sir, what about do you do catecholamine secretion assessment?
Paramita,
Yes, sir.
can you hear me?
Yes, sir.
See, I already mentioned these head and neck paragangliomas are belonging to the parasympathetic group, and they generally don't secrete. Less than 3% of the head and neck paragangliomas secrete. Okay?
Yes, sir.
So, in any patient who has a clinical symptomatology warranting the catecholamine excess, you can get those done. Like Professor Magnan said, they are getting routinely done. There is no harm in it, I would say. Secondly, I would emphasize here a point on the genetic testing which I asked Professor Magnan.
Okay.
See, more and more work has been going on this subject of genetic testing in paragangliomas. Earlier, medullary carcinoma of thyroid supposed to be the tumor which is supposed to be having the highest genetic penetrance, I would say predisposition. This paraganglioma has crossed even the medullary carcinoma, and almost 40% have a genetic predisposition. And it has been proven that it is the mutation in the genes leading to the succinate dehydrogenase group, which is responsible for these kind of tumors. The reason is, if you get genetic testing done, there are subunits of succinate dehydrogenase. If those mutations you find, like in the subunit B, those are the tumors have a highest probability of converting into a malignant transformation. If the patient has a succinate dehydrogenase D mutation, those are the patients have a highest probability of having familial tumors. Then in those patients with SDH-D abnormality, we need to at least test the first order relative to pick up the early lesions and treat them well. The idea is to pick up the early lesions in the first order relative before they advance to a bigger size and pose more problems. So this is very important, because in genetically predisposed individuals, the tumors are majority of the tumors are multicentric. There are multiple paragangliomas, and here I would emphasize, like Professor Magnus said, the angiography is useful. I would say angiography is most useful to find the multiple tumors. Sometimes there are small multiple tumors which you may not find with your regular CT or MRI, but your angiogram can pick up. So the multicentricity is another thing which is important in genetically predisposed individuals. So genetic testing in our country, it's not so widespread. I have heard and read in the Western literature, it is more and more common. And I have seen even through Professor Mario Sana's institute, they are getting genetic testing done now for almost every patient. And according to the American Society of Clinical Oncology, any tumor which has a more than 10% incidence of genetic predisposition should be assessed for genetic testing, at least for the first order relative. for more than 10%. This tumor has a more than 40% genetic predisposition. That's why in certain centers in the world it has become part of assessment. The genetic testing has become part of assessment, and probably Group Pathology ko Professor Mario Sana is doing genetic testing now for almost every patient. But here, to stay on the safer side, those particularly who are young individuals who develop this tumor, because in genetically predisposed people, it is amongst the youngsters, these tumors are very common. So if you find a paraganglioma in a young patient, it is advisable to get the genetic testing done to find multiple tumors, to find even catecholamine secreting tumors, and you can test the first order relative to find the early tumors in that.
Yes, yes. But Satish, we get these cells also in adrenaline medulla. So any association have you found about it? Was the cells besides the jugular valve area?
Pardon?
Besides the jugular valve area, we get in this carotid body area and adrenal medulla area also.
Yeah.
So have you found any association with those symptoms also, the adrenal medulla, etc.?
So catecholamine secreting tumors.
Yeah.
Those are functional tumors. I said those are rare. If they are, obviously they need the same treatment, surgery. Then it is more essential. But then you have to be more prepared pre-operatively, peri-operatively, post-operatively to deal with the catecholamine excess. So that is a different scenario, but this is uncommon in this. Professor Magnan, are you getting any other investigation done before taking up these patients for surgery?
No anymore. No.
Okay.
It's okay.
Yes,
one investigation. I look to the ear with otoscope. I don't see for the moment otoscopic image.
Okay. So volume badao. And one more thing, Professor Magnan, do you believe in limited facial, transposition approaches in any given situation, or by default all you go by the complete exposure like anterior transposition?
I have no systematic attitude. It depends on the case. And I choose and I decide anterior transposition of the facial nerve during the surgery. If I can perform and to respect facial bridge, I do that. But if I see the too complicated and is not useful for the patient to remove, and it is a trouble to remove all the tumor, I immediately perform anterior transposition. But the decision is during the surgery.
Okay, this is an intraoperative decision. So like this patient.
Satish sir, I think you need to get your the mic little more closer, and Professor Mannion's voice is echoing. So there's some. I'm getting many messages saying for the voice is not clear.
Sorry. My voice is not clear.
There is little echoing. There's an echo, sir.
Yes, but
ये picture भेजो.
Okay, and Satish sir, you can take your mic little more closer.
Okay, done.
Your voice is not very clear. So there's a question.
Please, Dr. Marita.
That MR. Yes, sir.
My voice is better. Yep.
Yeah. Now it's better.
Yeah, it's better now.
Yes,
so I will take it. Okay.
Satish sir, you can get your mic little more closer.
Yeah, is it better now?
Satish sir, your voice is little low, sir.
और इसको ये discharge हो गया. I am changing the battery. Maybe because of the battery.
Yeah, Arvind, just change the battery.
Yeah. So I have already washed up.
Sir, there is a question from Mr. Anirudh from Kolkata.
Yeah.
That is MR venography superior to CT angio in this context, you think?
Yes, MR venography, when you are doing MRI, you can at the same time do the MR venography. It's not then would be like an additional investigation. So it gives a good information of the entire dural venous sinus system.
Wait, sound is not clear.
इसको बढ़ा, कॉटरी बढ़ा. Are you getting any picture?
The picture we are getting very clear.
We are getting the picture. Your voice is not very.
What picture are you getting?
Sir, at microscope.
Yeah, microscope. You've taken incision.
Sir, before we start, you haven't told us the classification. So I think this is as the vertical portion is involved.
I will.
So
See.
it must be C2.
Okay, Paramita, I am coming to a question. First of all, the meantime I raise the flap and do a cul-de-sac closure, we will take all those questions, okay? So, just a few words on the incision. This is the extended retro-auricular incision which I am going to extend into the neck, the upper part of the neck, okay? Because this surgery involves the petrous bone, we'll do a subtotal petrosectomy, we have to do a blind sac closure first, as we have to go to the deepest area in the temporal bone, that is jugular foramen. And for that we have to follow from the neck the great vessels and the nerves, so we have to go in the neck and do a sort of neck dissection. We'll do a level 2-3 sampling as well. So this particular surgery, if you divide into steps, my first step after the incision and the flap raising would be a cul-de-sac closure. Then I would be going to the neck and define my neurovascular structures, take them into control, and then I will go to the vessels which are supplying to the tumor, so I take them into control so as to devascularize the tumor before I go to the tumor. Then we'll come to the temporal bone and we'll do a subtotal petrosectomy, and then we'll transpose the facial now anteriorly so that I can expose my tympanic bone and below that the jugular foramen. This will be the whole exposure part, and then we'll close the sigmoid sinus extraluminally above, ligate the jugular vein below, and we'll take out the tumor in toto. Okay, that will be the plan. Now, during this period, see what I am doing here is simply the flap elevation you can watch. I don't think there will be too many questions on it. During this period, we will take questions. So coming to your first question, the classification system. Okay? See, why the classifications are required? The classifications are required to communicate the tumor status among the surgeons, to plan the surgical approach accordingly. So the most popular classification for these tumors earlier was proposed by the Hugo Fish. The Fish classification has been very, very popular. Now after the phenomenal work of Professor Mario Sana, he modified the classification, and now the modified Fish classification is the gold standard what we follow. So what is basically in the classification? In this classification, they divide the tumor into 5 categories. The category A, the simplest one, are the tumor which arise which are limited to the middle ear. Got my point?
Yes.
Yeah.
The A1 are the tumor where the entire circumference of the tumor you can see on the otoscopy behind the tympanic membrane. And there is no tumor beyond that. All visible. A2 are the tumors limited to the middle ear, but beyond the otoscopic picture. They may be going to the Eustachian tube toward the hypotympanum, retrotympanum, wherever. Okay? That is A1. A2.
A2.
Yeah. So these are the simplest classification, simplest of the tumors. They are known commonly as the glomus tympanicum. And many a times we remove these tumors even by the trans-canal approach for the tumors which are probably likely to be A1. For A2 tumors, sometimes you may have to extend your approach a little bit by post-auricular or endoral, whatever. But they are simplest tumors you can remove, and you don't need anything extra for those tumors. Those are the simplest of the all paragangliomas. Class B are the tumors when these tumors extend beyond the confines of the middle ear. They are known as tympanomastoid paragangliomas. The reason is they extend to the mastoid or beyond the confines of the middle ear. So again the Mario Sana had divided them into 3 categories. That the third one is very important nowadays. The B1 are the tumors which extend to the hypotympanum. Simple. Hypotympanum is a key area because below is the jugular bulb. B2 are the tumor which along with the hypotympanum extend to the mastoid behind. Those are B2, and these two categories of the tumor, B1 and B2, you can always remove by means of your mastectomy approach, whatever you are well versed with, either intact canal or canal down mastectomy. Okay? Then the third category he has categorized is a B3, which is very important, particularly those tumors which go anteriorly and invade the carotid artery. And in that situation, your regular mastectomy doesn't give sufficient exposure, and it involves the Eustachian tube, where the function of the middle ear, if you deal with the Eustachian tube, radically may not work. So those are the patients which requires classically the subtotal petrosectomy. So these are B category of the tumors. Is that clear?
Yes, sir.
C category are the tumors which invade the carotid artery at various levels. In this, the C1 are the tumors which invade the carotid artery minimal at the level of the carotid foramen. Those are the C1. C2 are the tumors which invade the vertical portion of the carotid artery more. Like this tumor to me is C2. To me, this tumor is C2, which is invaded the vertical portion of the carotid artery. Then the third is the C3 tumor, where the tumor extends along the carotid to involve the horizontal portion. And C4 are the tumors where the tumor extends beyond the level of the foramen lacerum. Those are the C4 tumors.
Satish, you need to explain this muscular periosteal flap and the cul-de-sac.
Yes, Narayan. See, this is in contrast to a regular flap, I tell you. That's an important point you mentioned. Whenever we do any mastoid surgery or any surgery from the retroauricular area, we have a habit of making a flap based inferiorly on the occipital artery. Okay? Here in this condition, we are going to sacrifice the occipital artery, as this is likely to be supplying the tumor. We have seen on the angiogram the two big vessels likely to be occipital and the ascending pharyngeal, or probably the posterior auricular. So once you sacrifice that, we cannot use the inferior base flap. Okay? So here what I am doing, I am raising a flap. What is the need of this flap? Because once we in the end do the obliteration with the fat, to keep the fat in place, we need a flap, and this flap I am raising superiorly base. Intentionally, I am raising a superiorly base flap. Can you see this? Hello?
Yeah,
Yes,
it's
sir.
clear.
Yes, sir. Yes, sir.
Because then it will be mainly based on the posterior branch of the superficial temporal with lot of other communication from around and the opposite side. So this will be a safer flap as compared to the occipital artery phase. So this will raise at the end of the surgery. This will be a very useful flap to keep our fat in place. Simple. That's it. And we will suture it lower down with the muscles which are attached to the mastoid process, the digastric, the stenomastoid, and those muscles. So to give it a...
Can you show your second layer, what you preserve for second layer muscular periosteal portion, cul-de-sac? Can you show that?
Pardon?
The muscular periosteal flap which you're using for second layer closure of the cul-de-sac. Can you show that area?
Yeah, that for the cul-de-sac.
Yes.
Yeah, here. That is going to be here. I have not split the canal yet. I will show as I split the canal. And for that matter, Narayan, most of the time I use the cartilage to reinforce my cul-de-sac from below. Yeah. I suture both the tragal and the conchal cartilage together. Okay? And that works very well. Okay. The idea is to reinforce the cul-de-sac, it should not break. Okay?
Okay.
Sir, what is the pre-op hearing status of this patient?
This patient has a mixed hearing loss, severe mixed hearing loss.
Okay.
And that gives me a suspicion that if the inner ear is involved somewhere, though radiologically it doesn't look like the inner ear is involved.
Okay, sir.
So if the patient has a sensory neural hearing loss, that gives you a good idea that the inner ear is involved. And in that,
but in most of the cases, we get mixed hearing loss.
not most of the, it starts with the conductive hearing loss.
Yeah.
And as the inner ear part is getting involved somewhere, because as this tumor ascends up, it's not uncommon for this tumor to erode the cochlea and the vestibule anywhere. We have seen number of patients where the cochlea is completely destroyed by the tumor. Now see, I am at the level of the canal. Can you see here?
Yeah.
That is the spine of Henle. That is my mastoid process here. Is the picture good there?
Yes, sir, it is good.
See, this is the level of the mastoid process, and what I am doing here, I am separating these muscles attached to the mastoid process. These muscles, if you see from order, from lateral to medial, this is sternomastoid. Deep to that, see the sternomastoid is coming from here like this. Okay? Then deep to this a muscle going like this, that is splenius capitis, and deep to that is a longissimus and your digastric. So I am just segregating these muscles from the mastoid tip for that matter. Okay? Professor Magnan,
Yes, sir.
Professor Magnan, any change in your approach, incision or anything? Please illuminate us whenever you feel like.
But I start by the neck.
You start by the neck.
By the neck, yes.
Yeah, we will also go in the neck first.
Okay.
We will also...
Any other flaps that Professor Mannion would say, or this is the same?
The flap is a little bit different, but I don't think it changes too much the panel result. No, the same, quite the same. Almost the same.
So Dr. Sandeep Karmarkar is asking, what is your opinion on association of glomus tumors along with acoustic neuromas on the same side? Any reports which suggest such incidents and any genetic predispositions?
Convey my regards to him. Number one, I have seen that patient, his patient only, having these two pathologies together. I have never seen earlier. We did a skull-based workshop in Pune, and he posted a case who was treated earlier for a paraganglioma, glomus tympanicum, and then he developed acoustic neuroma, and we did a translabyrinthine dissection of the acoustic. So otherwise I have never seen before, though it has been reported. These are two different pathologies, but Professor Magnan must have seen in his life such combinations. That means it's not common. Not, yeah. Here I would like to mention that these paragangliomas, the multiple paragangliomas in the same patients are not uncommon. Particularly familial. Particularly familial. We have seen these paragangliomas in combination with the jugular paraganglioma in combination with a vagal paraganglioma or a carotid body tumor. We have seen couple of times. They are not uncommon, and then decision making is crucial. When you have two tumors on contralateral side, you need to take into account a lot of facts, particularly the cranial nerve and the carotid artery conditions in decision making. See now what simply I have done. I transected this canal quickly using the monopolar, and our aim is to bring out this canal and do a closure. As we do a subtotal petrosectomy, to prevent future infections, we have to close this area completely. So we will bring out the sleeve of the canal and then do a see this is the canal. Can you see from this side? This is the canal on this side. And what, yes?
Coming back to the same thing where you're going on this, talking about the multiple Another Joshi had a case which he did fantastically as a subject. I just stood by her, but she did the whole case herself.
Yeah.
Patient with the glomus tentanicum or glomus jugulare and a carotid body tumor on the same side.
Yes, yes. There's such.
We also had one patient who came from the north of India, who had an acoustic and a glomus on the same side. So he refused to get operated.
Focus. Yeah, these combinations are common. For the audience information, the most common complication is a bilateral carotid body tumor. Then the combination of a jugular paraganglioma and a carotid body. Then a combination of the vagal and paraganglioma and a carotid body. So such combinations are not uncommon. And you need to take a call according to the situation. Yes, Paramita, we can take question meantime. See, this external artery canal is being separated from the cartilage, and the skin we will take out to the canal orifice and shoo it outside. Okay? This skin is being separated from the cartilage. Can you see the canal cartilage?
Yes.
So you have to be careful not to perforate the canal skin, otherwise you have to put a extra suture on that. This particular step is very, very important in the surgery because the cul-de-sac closure should be efficient. It should not break in the post-op period to prevent infection. So this skin should be separated from the cartilage and the soft tissue around to be preserved along with the cartilage so that we can supplement with another layer from below. So even if your sutures break, what we put outside, we have a second layer to prevent ingrowth of the skin into the cavity again. We are bringing out the skin. We are trying to prevent the ingrowth of the skin. And see this, how this skin is being skeletonized, and this will take outside. We'll take outside. We'll pull it from outside and sew it with a non-absorbable suture vicryl. So this 5-minute step is a very, very crucial step. Yes, boss.
Dr. Devkumar is asking, do you have any special counseling and pre-operative content for this patient, especially grade C or D patient?
Yes, that's very important. They require at least 1 hour of counseling, video counseling for many regions. I told you this jugular foramen is situated at such a strategic location, so deep, surrounded or in that area, traversing a lot of neurovascular structures. The carotid artery, jugular bulb, cranial nerves, facial nerve above, okay, and the dura in the medial side. So the complication rate, the threshold of complication is very low, and you have to apprise the patients with, first of all, the available options of treatment and the possibilities of complications. Particularly, like for example, to be very, very specific, the facial nerve transposition. We all know, we discussed in the temporal bone session how the facial nerve has its blood supply coming from above and below to the descending petrosal and the stylomastoid arteries. And once you take the facial nerve off the canal to a new area, the vascularity is taken off, though it acquires in the new bed over the period of time. But that vascularity which you take off results in some sort of facial weakness. And if a properly done transposition, you know, at the end result after 6 months or so, we have seen to the level of grade 2. So that transposition should be properly done. It requires utmost care in handling the facial nerve to prevent the damage, which I am going to demonstrate this after I go to the neck. So all this counseling is required to all these patients. about closing this extraordinary canal and doing a subtotal picturectomy, it inherently involves giving a patient a conductive hearing loss. So we need to counsel this patient that this is the part of this approach which involves a conductive hearing loss for the future. So all this is part of counseling. Thirdly, the disastrous complication, we have to, you see in this patient how the tumor is engulfing the carotid artery, which I am going to separate either in the subperiosteal, or if the adventitia is involved, I will separate in the subadventitial plane under microscope. That will be the most crucial part of the surgery. So dealing with the carotid artery to that level may result in complications. Even if you don't damage, may result in vasospasm, thrombosis, thromboembolisms. So all these possibility of complication the patient should be apprised of. So the counseling is very, very important. That's why these tumors are known as complex tumors. The venous system, sometimes the venous adequacy on the opposite side is questionable. Yeah, second layer is this. See, this is a conchal cartilage behind, which is being sutured to the tracheal cartilage anteriorly. See this? To supplement the closure from inside. Let me centralize. Is the picture good? See this, the tracheal cartilage to the conchal cartilage. That is good enough. If it is done properly, there is no question of the give way of the this thing. Suture line. So the important thing is the extraordinary canal sleeve should be taken out and sutured with the absorbable vicryl, so you don't need to remove the suture. If you remove the suture, it may give way and again the epithelium may ingrow. Secondly, this entire suture line, see, being embedded from below with another suture line suturing the tracheal to the conchal cartilage. Sometimes we raise a flap that is based on the posterior auricular artery inferiorly, and you can supplement this closure. See this now completely closed from inside. You don't see the canal suturing now from inside. There is the second layer which has come over it, and it works very well. And below that, whatever fat we obliterate, over obliterate, will come over that. Okay?
Yes, sir. Yes, sir.
So that's a very...
About the incision, you haven't told us about the incision.
Yeah, this incision I told you, this is the extended retroauricular incision going almost an inch above the canal, inch behind the canal and inch below. Can you see this? The reason is this area we need to drill beyond the confines of the sigmoid sinus. We have to go behind the sigmoid sinus to do a decompression, to do a extraluminal packing, and we have to go below in the neck now. Now with the microscope, I am doing everything with the microscope. How is the picture? So now I will be going through this microscope into the neck. Yeah, I am bringing to the minimal magnification. To take the vascularity first into control before I handle the tumor. As simple as that. And to tackle my neurovascular structure in control first before I go to the tumor. These are the two regions, Narayan. I am going to the neck first. Anyway, you have to go to the neck. Why not first? Like Magnan sir said, he goes to the neck first before doing anything. Am I correct, sir? Is there any reason, other reason for that, or the reason which I mentioned? See now, see the extraordinary canal. Can you see the extraordinary canal? Let me focus onto it. And see this tumor, which is pushing from the middle ear, this tympanic membrane outside, and see the pulsations of the tumor. Can you see? Yeah, let me focus, Oh, see the pulsations of the tumor. And that's how it gives a classical pulsatile tinnitus particularly when tumor comes in contact with the ossicles. Okay? Now,
I just want to know what are these criteria of approaches and very correct approach according to this?
criteria for selecting the approaches. See, as I mentioned about from the classification, according to the tumor status, the involvement of the structures, the stage of the disease, I would say, we take a call. For like this tumor, which is a C2 tumor. Now this is cervical extension. This is a C2 tumor. In C2 tumors, the vertical petrous carotid is the main structure to be taken care of. Now to take into control the vertical petrous carotid, we need to transfer the facial now, and for this the infratemporal fossa A, classical infratemporal fossa A is the approach of choice. Can you see this now here? Anybody? What is this? This is greater auricular. This is useful now sometime for the facial now, reconstruction. But nowadays we have almost given up this now, and we are more and more using the sural now for the facial now reconstruction. Yes. Yes. If there is pre-operative facial nerve weakness, first of all that nerve has to be sacrificed. There is no doubt about it. The facial nerve is involved by the tumor, and that has to be sacrificed. Okay? And we will reconstruct that at the same time at the end of the surgery using, as I told you, the sural nerve to the proximal segment, from there to the parotid. Okay? Now, the biggest issue is, the problem is when the patient has a pre-operatively normal facial function. Okay? Patient has a pre-operatively normal facial function, and intraoperatively you see the facial nerve is involved by the tumor. And then you have to take a call, which is a very, very difficult call. Got my point, Narayan?
Absolutely.
So, our criteria in that situation, I tell you, if you look at the architecture of the facial nerve, facial nerve is formed of lot of vesicles which are covered by the endoneurium. Then a lot of endoneurium vesicles are covered by perineurium. And those are covered by epineurium and then periosteum. Okay? If the tumor is approaching the facial nerve to the level of the periosteum, we preserve the facial nerve. There is no question of sacrificing it. Even if it is approaching the periosteum. Even if it is approaching the epineurium, we can remove the epineurium and keeping the endoneurium intact. But if the endoneurium is involved, we will take a call of resection and anastomosis. That is our philosophy. Professor Magnan, what is your protocol for the facial now?
When the patient is intact, preoperatively, when there is a complete facial function,
Yeah. Even if it is involved by the tumor.
Yes, I agree. That's a good method.
So you mean you would leave the tumor or the nerve there?
Yes. I explained after that the case of the patient, but you are right. Because I remind 2 cases I did that, and after 1 or 2 years I have to go back because there is a total facial paralysis and to perform an anastomosis. So I don't know if my strategy was a good strategy. It was a good strategy for the beginning of the patient, but on long-term follow-up, the result was the same. I have to perform the facial grafting.
But Professor, would you do the same thing, leaving the tumor in the young patient also?
Yes, I did that.
Okay, this is one philosophy. The reason is the facial nerve is so important a nerve that sacrifice of that nerve requires to be, you have to think twice before that.
Yes, for me, facial paralysis is terrible, and I have to explain to the patient, even in the second stage that you have to do that. But for the patient, you cannot believe that you were obliged to sacrifice the
pedal.
This is the problem. If you do in the first stage.
But you know, even I have gone through Professor Mario Sana's series, and in his series, up to 10% of the patient, they find the facial nerve involved, which was earlier preoperatively normal.
Yes, I have the same experience.
Yeah.
Not the same strategy for the patient. I prepare to perform the second stage, not immediately, because it is terrible for the patient to have a partial paralysis post-operatively.
So, Satish, can I make a point?
Yes, yes, please.
Okay, what we are dealing with class 3 tumors, and I think in all these class 3
Tumors, I would do an anterior transposition, which would give this patient a grade 3 or even a grade 2 House-Blackman group facial paresis post-operatively. So it's no way we are going to be retaining the facial nerve intact unless we do an intact bridge or intact fallopian bridge technique. So we always explain that the best results for after transposition are grade 2, which we do get often, but it could also be grade 3. On the other hand, when you resect a nerve which is involved, you're giving the patient a best result of grade 3, maybe even grade 4, but usually grade 3. So all these are explained preoperatively to the patient, and I think the take-home message is that if the facial nerve is involved, I would rather sort of excise that segment and do a cable grafting and maybe do it.
I believe in the same fact, in the same philosophy, particularly in the young patients. Again, I would say, see where I am working. First of all, this is level 2. Can you see the digastric muscle there?
Yes, sir.
So, first of all, as I mentioned earlier in these glomus tumors, and I would mention one more fact, a certain percentage of the glomus tumors or the paragangliomas, jugular paragangliomas, they turn into malignancy, up to 10 to 20% in certain series. And this malignancy is not defined histologically. The malignancy, the criteria for malignancy is the metastasis, regional or distant metastasis, not histological. So, in all these cases, patients, it is always better to do a level 2-3 dissection to confirm that sampling is important and send for frozen section to know whether there is any metastasis to these known paragangliomic tissues, that is lymph nodes, and that will be considered as a malignant if it is. Because in that situation, if it is a malignancy, then you have to follow with a comprehensive neck dissection and the radiation later on to improve your results. So the malignancy is not defined by histological criteria. The malignancy is defined by metastasis. This is unique for the paragangliomas.
Satish, can I make one more point?
Yeah.
That brings us back to the residual tumor. As well, wait and observe rather than give radiation for the same reason, because malignant transformations are known post radiotherapy.
Yes.
Would you agree, Satish?
Yeah, yeah. That's why the high dose radiation is never given to such benign tumors.
Exactly. So even if there is a residual, probably wait and watch, or you will probably operate it if necessary.
Narayan, these days now there are a lot of reports. You know, there is a huge fight in the last EBM at Tata Hospital.
I know that. I know that.
Regarding the role of radiotherapy, there was some people, radiotherapists, who are in the favor of radiation as a primary modality and publishing some papers, which were denied on the fact that the observation period was too less. If somebody, we all know these tumors are inherently slow growing tumors. We all know. Now, if you say that your 5-year post-radiation series has a control rate of 80%, 90%, that may not be, I mean, say, related to the paraganglioma relevant, because these are slow growing tumors. There is no study showing 20 years down the line the role of exclusive radiotherapy. And for that matter, for the audience, the radiation doesn't kill the tumor. Radiation doesn't kill the tumor. Radiation leads to fibrosis of the vessels supplying the tumor, resulting in tumor control. That results in tumor control, not cure. So before giving radiation, you have to think twice what kind of patients you are giving. Our indication for radiation are very clear. Radiation is given as a sole modality or adjuvant to certain group of patients. So we give radiation to patients, particularly post-surgery when the tumor is involving certain vital structures like intracranial structures, pica, ica, brain tissue, even the sinus which cannot be resected. Then obviously you have to use radiation. Okay? As adjuvant therapy. Primary therapy in elderly patients. See, these are slow growing tumors. In a chunk of patients, these tumors do not grow at all. Chunk of patients. If you go to the publications who have studied the natural course of this disease, you will find in a majority, in a chunk of patients, these tumors do not grow over a long period of time. Can you see something coming into the picture?
Satish, there are a lot of juniors watching, so you must explain the steps that you're doing in the structure.
Okay, let me show you.
Yes, sir. Sir, I would just like to say I'm getting many messages saying that everyone's voice is echoing. So whoever is there at sir's end, can you just please check to this, the voice quality?
Can somebody check the voice quality, please?
Because I am getting numerous messages saying that the voice is echoing.
Let me ask. So I want to show here some important anatomy. Like Narayan asked, what I am doing at the neck. See this. Can you see some nerve coming into the view?
Yes, sir.
Can you see this nerve going anteriorly, transversely? This nerve is going transversely, crossing the carotid artery. This is hypoglossal nerve. Can you see?
Yes, sir.
Hello?
Yes, sir.
And this another branch from this nerve is coming down. Can you see this? What is that? Everyone?
Lost.
From this nerve, what is that? That is ansa hypoglossae. Can you see that or not?
Yes, sir.
Now I'm just ligating this tributary to this vein so as to open this compartment better for your snipe there. See now the carotid sheath and see this nerve running on the carotid sheath. That is ansa hypoglossae. Can you see this?
Yeah, it's clear, Satish.
Yes.
This carries the C1 fibers through this nerve, and this is important now in our practice now. ANSA is not a useless nerve, I tell you. ANSA we use as a material for reconstruction of the marginal mandibular nerve in facial nerve palsy. We use ANSA for the non-selective reinnervation of the recurrent laryngeal nerve. Can you see the ANSA very clear?
Yeah, very clear.
I hope the picture is good.
Yes, sir.
Picture is good.
Now see what is there below. I told you the ANSA running on the carotid sheath. And this supplies all the muscles in this region, strap muscles in this region. So if I resect the sheath, part of the sheath, you will find the most important structure coming from below. That is carotid artery. Can you see the carotid artery? Hello?
Yes,
Yeah,
we can see it.
Can you see the common carotid artery? Let
Yes,
me
sir.
open up the sheath better. Can you see the common carotid better?
Yes, sir.
And the carotid fork for that matter. See the carotid fork.
Yeah.
So in the beginning, this external carotid is anteromedial to the carotid artery. See, this course is so funny. And both the carotids are being crossed by the hypoglossal nerve. Is that very clear?
Yeah, very clear.
I have separated this lymph node tissue in this region separately for sampling. You know? See the carotid and the jugular very clear?
Yeah.
Now, as I move up, you will find some interesting anatomy here. So here we will take the control of the carotid in case required any time during tumor dissection. So this is neck.
I'm out of the Zoom.
I am in the neck.
Keyboard needs to be Zoom detected.
And the important structure in the neck above is this digastric. See this? Digastric is one structure. As long as you are lateral to the digastric, you are away from all important critical neurovascular structures. See this? Digastric. This lateral structure is what? Digastric. Now, I mentioned there are certain vessels going to the tumor. And those vessels going to the tumor are from the external carotid. And those are the branches, most likely, I would show you here, will take them into control. Now, before that, we have to be careful here as you go to the upper part of the jugular. Because upper part of the jugular here is most commonly crossed by the accessory nerve. Most of the time, the accessory nerve crosses the jugular. Around 70% or more, it remains lateral to the jugular. 20 to 30%, it remains medial to it. Okay?
Satish, can you also show the relationship of the jugular to the transverse process?
Yes, yes. Why not? I will. That is important, Narek. Oh.
A little bit of the oozing here. Let me control. Yes. Now, Narayan, what asked is a very important question, and I would come to it for more reasons. See, the area which I am pressing upon. Everybody, Paramita? Hello?
Yes, sir. Yes, sir.
See, this is the transverse process of first cervical vertebra.
Yes, sir.
Which Narayan is asking, and this is one of the most important landmarks. For many reasons, I will tell you. This is the transverse process which is behind and medial to the jugular vein. And through this transverse process passing is a very, very important vessel, that is vertebral artery.
Yes, sir.
These jugular paragangliomas, there are a lot of reports, as they advance, they involve the deeper area, the vertebral artery, the extradural vertebral artery, as well as the intradural vertebral artery sometimes. And what Mario Sana has modified in the classification also, the involvement of the vertebral artery has been given a different stage. Stage V, E and I. E is extradural, VI is intradural. So for junior colleagues, this vertebral artery, how it courses? There are so many compartments of the vertebral artery segments. The vertebral artery arises from the lower part of the neck, from the first part of the subclavian. Then it ascends to the foramen transversarium of the 6 cervical vertebra. So until then is the first segment. Then through all the 6 vertebra transverse process foramina, it passes to the C1. This is the C1. If I drill this bone, my vertebral artery is coursing through it. Okay?
Yes, sir.
And I am going to show you some important landmark here. So, this vertebral artery, after this, take a posterior course like this. Deeper. Vertebral artery is from my finger here, more than 1 centimeter deep from here. It courses behind over the posterior process of the arch of the atlas. And then it goes further medially and deeper to pass into the foramen magnum. So that is the third part, from the C1 to the foramen magnum, and fourth part is from the foramen magnum to the formation of basilar artery.
Yes,
so
sir.
this vertebral artery, we should know the landmarks. See, once I do the mastoidectomy, this is mastoid here. Once I remove the mastoid process, our fundamental is not to go 1 centimeter below to the level of 1 centimeter depth. Meaning that within 1 centimeter you can go more than 1 centimeter deeper. But beyond 1 centimeter you are not supposed to go 1 centimeter deeper, otherwise you will end up injuring the carotid artery, this vertebral artery.
Yes.
From the lower border of the medial aspect of mastoid. Once I remove the mastoid, I will show you. This is important for the otology surgeons also. The lower border of the mastoid, the medial aspect, the carotid artery is 1 centimeter below and 1 centimeter deeper. And in that region, we have to be careful. You should palpate this process. This is one of the most important, I would say, landmark for the vertebral artery.
Yes.
So Narayan, your question was valid, very important. This is a huge landmark. We should know it. Now this is the digestic which I am going to slowly cut away to improve my exposure here. I cannot cut the digestic as a whole. The reason is immediately underneath the digestic is the vertebral artery. Number one. Above and medial to the digestic is going to be the facial now. As it leaves the temporal bone. That's why in parotid surgery we take the digestic as one of the important landmark. Okay, now retract. Now, can you see some vessel, horizontal vessel, this one?
Yes, sir.
Can you see that vessel? This is the vessel which is going to the tumor we saw on the angiogram. This horizontal vessel. And this is from vertebral. See that?
Okay.
Narayan?
Okay. Yes, sir.
So I will here pani dalo. Thoroughly coagulate the length of this vessel. This is one.
So then the branches of the external carotid, like the superior thyroid and the ascending parietal will be...
Yes. See this, once you look at the occipital artery, there are certain landmarks. Number one, it runs deep to the digestic.
Yes.
Number two, at the same vicinity of the hypoglossal nerve. See the hypoglossal nerve?
Yes, sir.
And same vicinity, and see the another vessel. This vessel I will completely, thoroughly coagulate. This is one of the major feeders to this tumor, section. This is my main region to come to the neck. Hold, pocket. Retractor. So I am slowly moving towards the upper part of the neck. Okay? And here my aim is, see this, all these vessels. All these vessels, I will coagulate them. These are all supplying to the tumor for that matter as they go up.
What is the average blood loss in this surgery, C or D stage?
Depending upon the surgeon, depending upon the approach, depending upon the embolization, depending upon the blood supply to the tumor, vessel supplying to the tumor, there is no hard and fast. You can't talk like average.
And how often you ask for embolization?
Pardon?
How often you ask for embolization?
Why?
He doesn't
For
do
embolization. What is the criteria to embolize the case before?
I belong to a different thought, and I will tell you the reason. I tell Narayan, I will ask Magnan sir at the end of the surgery, how much is the difference in the blood loss when they embolize and here when I don't embolize. You will not believe, there will be no difference. See, this is the external carotid which is ascending up.
Yeah.
This vessel ascends from here up in the parotid. From here, it ascends up in the parotid. So now we'll take number one, the control of these vessels. First of all, we have to see the branches to prove that this is external. Okay? Now can you see the branch number one? Branch number one. Can you see here?
superior.
Yeah, this is superior thyroid. This should be superior thyroid. Just above should be the lingual in vicinity of the hypoglossal. So you should, see the lingual.
Yes, sir.
So you should at least see the two branches to confirm as external carotid. Minimum two. See this? And now, first of all, I will non-tooth. Give me a non-tooth. and give me a thread. दे कुछ डालने को. This is my fork. See the carotid fork? And this deeper vessel is the internal carotid. Can you see now? See this?
Yes, sir. Yes, sir.
That is our external carotid. What I'm looking at in this vicinity here, sometimes you find, which in this patient should be, this big vessel going up, this should be the ascending pharyngeal.
Pharyngeal.
Just to stimulate a discussion, Satish will explain why he doesn't embolize. Exactly, he's going to the ascending pharyngeal and he'll show you the other branches also. He'll tell you why he doesn't.
I may take...
to embolize all the tumors, and I find that pretty useful. Though well, Satish has a very valid reason why he doesn't embolize. Satish, you can talk about it now that you're on the branches of the external pharyngeal.
Yes. Yes, Narayan.
Yeah,
so
Satish is an excellent surgeon. Okay, so for lesser mortals like us, I think we embolize.
See, the bleeding which frightens you is the region that makes the surgeon look for all those other options. You know, that is one of the...
So when you're taking the control of this external carotid artery,
Pardon?
As when you're taking control on this external carotid artery, which location will you do it? As proximal to it or?
Yeah, as proximal as possible. As proximal as possible. And this is just a control. I am not ligating it at all. Got my point?
Yes, sir.
This is just a control. I would prefer to take a umbilical tape rather.
Yeah, umbilical tape is...
Protect the artery protect. Now, second, idhar laga retractor. This is internal carotid. Can you see?
Yeah.
We have not seen the other cranial nerves yet. This part of the neck is very, very important from here, you know. Then the next thing I am going to take into control or to expose you are the other cranial nerves. Now see, what is this? That is vagus. Can you see? This is ansa. This is ansa. And see in the depth, that is vagus.
Yeah.
Can you see the vagus?
Yes, sir.
Yeah.
See very clear?
Yeah.
So 10th and 12th. My 9th is going to be up over here, and I have to be careful as majority of the time it crosses the jugular. You know? That could be the nerve. Can you see the accessory now?
Yes.
Can you see?
Yes, sir. So can you focus a little more?
Yes. Can you see the accessory now over here? See the accessory now?
Yeah, now it's clear.
It is crossing the jugular here, okay?
Yeah.
Yes, cut. Give me a point down. Yes. So now we have not seen the 9th nerve so far. The reason is 9th nerve is quite high up, and when we resect the styloid process, go close to the jugular foramen. I'll show you the 9th as well. Okay? I hope it is so clear so far.
Yeah.
Give me a hello.
Satish, since you've gotten the control of you're showing the external and internal carotid, can you now explain why you don't embolize?
Yeah, the reason is having the control of these vessels and taking these vessels which are supplying to the tumor intraoperatively into control reduces the bleeding to the level what you get with the embolization. Embolization, if you do a very good embolization to the microvasculature level, that may make the difference. That may make the difference. See the control of the common carotid here. See this?
Yes, sir.
Narayan, having done this and having left the uppermost part of the neck here, now I will move on to the. Now I will move to the mastoid. So I hope you got the idea that going to the neck and taking to control these vessels and the nerves, visualization of the nerve to follow and the jugular and the carotid is so important as you go to the jugular foramen above later. Is that clear?
Yes, sir.
Yes, yes.
Narayan, any point to make here?
Yeah, I think I was trying to prod you into giving the answer, but okay, Satish believes that, see, he's taken control of the external carotid artery over here, and any branches that are supplying the tumor from the external carotid system, he's already taken control of the main external carotid artery.
And Anand, Narayan, while delivering the tumor, I will take in between the control of the external carotid by means of my bulldog.
Yes, yes.
To further reduce the bleeding while dealing with the tumor, and that really makes a difference. Only that time, not all the time.
So Satish himself believes that he's getting good control surgically. It's like intraoperative embolization, what he calls. Whereas we believe in embolizing these tumors, if I get it, the idea of embolization is also that in a couple of days, the tumor becomes almost like a solid mass. If it is not embolized, it remains sometimes very soft and it comes out as very soft, friable pieces. Whereas if you embolize it, I feel the consistency of a tumor is far more easier to remove than in a non-embolized subject. Professor Manian, your views on that?
I agree. I fully agree. Embolization helps you a lot.
Every case.
Every case.
Yeah, majority of the centers in the world, they embolize every case.
But we have to emphasize a good embolization. You say that. Embolization is not enough. You need a good embolization. And
yes.
This changes, really.
So does it help you in your tumor removal in terms of consistency of the tumor?
Yes, of course.
Narayan.
The nerve become dense thanks to the embolization. Yes. This is the difference.
Narayan, in the jugular foramen and particularly the petrous bone, when it is invaded by the tumor, that remains the commonest cause of so-called recurrence when the tumor is left in the petrous bone. Right. This embolization makes the tumor difficult to ascertain many times and may result in overlooking the tumor into that region. Okay, for the audience who have joined now, later, what I have done, this is my incision, retroauricular, this is the pinna anteriorly, and this is how I have gone into the neck. I dissected these lymph nodes. Let me send them for the frozen. In case, meantime, we'll get the report. Okay? Hello? Yeah, we'll send them for frozen for that matter. This
There's a question from a resident, Dr. Faiz from Mumbai. He's asking to avoid post-operative neck pain. How will you avoid post-operative neck pain while handling these muscles?
By handling, yes, there remains, and the analgesics are always part of the post-operative management and physiotherapy, all that it takes care, it doesn't bother much. Now the next part, I have come the most important for the otologist now. Ulta kar. Direction change. Is the subtotal petrosectomy and facial nerve transposition. See, I am using the bigger bar to accomplish fast here. This is the crude work. I am quite lateral. So I will, and see, we have seen on the scan, the mastoid was absolutely normal. Most of the mastoid part is normal, particularly the lateral part, so I can go ahead faster here. That is the canal wall.
So Dr. Pawan Singh is asking, how do you decide for facial nerve sacrifice? What is your criteria?
Criteria I have already told. Pawan may not be there that time for again. Facial nerve, you need to go to the structure of the facial nerve. If the tumor is up to the periosteum, I will preserve the facial nerve. If the tumor is involving the epineurium, I will sacrifice the epineurium and preserve the nerve. But if the tumor involves the perineurium, I will not take chance, particularly in the young patient. I belong to the thought of sacrificing the nerve and do a resection anastomosis. So, and that may come many a time as a surprise intraoperatively in a patient who had a good preoperatively normal functioning nerve. ये दूसरी दे यार खुल लूज हो गया ना. So now quickly I will do this drilling part.
So Dr. Rajiv Kapila is asking, when do you decide to do subtotal petrosectomy in case of glomus? Is there any exception?
Yeah, in tumors where you need to remove the tumor from the middle ear cavity, from the Eustachian tube around the carotid, jugular foramen, obviously you need to obliterate the mastoid. This is not going to be a good, as you have to obliterate the Eustachian tube, this is not going to be a functioning middle ear anymore. So subtotal petrosectomy is an integral part of this procedure, and the approach that what we call it as an infratemporal fossa type A approach, and that involves exentration of all these air cells to remove all the mucosa, exentration of all skin of the extramedullary canal everywhere. See this, the lateral part of the skin we have already cut, the medial part I am going to remove. Complete removal of the skin and the mucosa, and then obliterate so that no question of post-operative cholesteatoma or mucocele remains.
So sir, now what is the next step that you are looking for in this?
Just complete this petrosectomy, subtotal petrosectomy. I will exenterate all these air cells fast.
Satish?
Yeah.
There is a 65-year-old lady having occasional bleeding from the ear, such a tumor, no involvement of facial, no involvement of lower cranial nerves. Would you operate her, or what would be your line?
Not really. I will observe with the serial imaging. Because I told you this tumor doesn't grow in 100% of the patient very fast. So in elderly patient, the treatment is altogether different. In elderly patient, the strategy is more and more observation. If tumor starts growing in those elderly patients, you can use radiation rather than taking them for surgery and giving them cranial nerve palsies. So in elderly, the protocol is altogether different. Only radiation when the tumor starts growing. सब सो रहे हो यार. पानी मोटा ले पानी
For elderly patient, I fully agree. To scan the patient is a much better solution. But also, in some cases, we prefer to use embolization alone without nothing else than radiotherapy. Because after radiotherapy, it's very difficult to do anything. You perform embolization, this reduces the blood supplies, and this reduces the potential of growing of the tumoral process. So this can be also an additional factor in elderly patients.
Also, Dr. Amit Keshri is asking that long-standing facial nerve palsy, will it respond to the cable nerve grafting?
Yes. Still you have to do a cable nerve grafting. And for that matter, facial nerve, you may have many questions. For the audience, we'll do very soon a dedicated full day webinar on facial nerve. Full day webinar on facial nerve. Facial nerve in itself is a complete subject. And in that, first of all, we'll show in cadaver more than 50 varieties of techniques of facial anastomosis and reanimation. And then we'll do 2 or 3 live cases of different situations. So facial nerve is a different subject. To answer your question, yes, long-standing means it should not be more than 2 years. If more than 2 years, then chances are very feeble. Though I remember Mohavani sir was saying his experience of in a lady with a 7 years long-standing palsy, did nerve grafting and found some signs of improvement. But the theory is, in long-standing, after 1 to 2 years, the motor end plates go atrophic, and then stimulation of the nerve is of no value. What is it? You know,
I'd like
so
to add point there, Satish. It's in a younger individual that can take a slightly delayed facial nerve grafting chances, but in a little elderly age group, it may not regenerate as effectively. In a
yes,
younger patient, the tone of the muscles are good; they don't atrophy that fast, so you can actually push a limits from between 1 year to 1.5 years to 2.
yes, exactly. That stands true everywhere in elderly and youngster. That is the body's physiology. Pani dali sir.
Ask Professor Manian. Professor Manian, what are your views on facial nerve grafting, timing of facial nerve grafting?
As you say, I perform, if there is no facial paralysis before, I try to preserve the nerve. But if there is a facial weakness, I perform first anastomosis with a loss of nerve. It is possible, but it's not always possible in this case because it's sacrificed. And I use a sural grafting.
Pani
I have
dalo.
to go very far at the geniculate ganglion to the bifurcation of the nerve in the parotid artery.
No, but what is the time duration? Say, there was a question about a long-term facial weakness. So if a patient has 1 year,
We have to wait more than 1 year, even 2 years, to have a good recovery.
Oi, ये निकल गया.
So which graft you said? Which?
We sural nerve.
Sural. Okay.
With the anastomosis of the nerve.
बस पानी नहीं डाल रहे हो यार. सो रहे हो.
First is about, we have 6-8 months of some time to some regeneration, but we have to wait 80 months and even.
Now, can you see the sigmoid sinus coming into the picture?
a patient having a long-standing facial paralysis.
Yes, I have some, and there is an explanation for that. Fortunately, the facial nerve innerve a plastisma muscle. Plastisma muscle, there is no atrophy, or atrophy is a very long time. So even after long-standing facial paralysis, you can perform graft and you can get good rest.
Jaishankar sir, so this elderly that we are mentioning here again and again, what is the age? I mean, it is more than 60, you mean to say?
It's not necessarily more than 60. There's no fixed. A lot of elderly people above 60 will probably get very offended about it.
So what is elderly? What is?
Elderly means above 70 now. And also we look at the general condition of the patient. In case the patient is very frail, not worth taking a risk of operation, you would try to offer them alternative modes of treatment. Because weaknesses of the cranial nerves would probably be very poorly tolerated by these patients. Whereas you have a very healthy looking 70-year-old man who you think can really tolerate the procedure, you may just about go and do it as a case. So you have to select your patients. Mr. Maniam, would you agree?
Yes, I agree, of course. But for me, every patient is age more than me.
Narayan.
To be serious.
Narayan.
In fact, you can say even less than 60. Why? Because swallowing problem in elderly patient is terrible. It's a disaster, even in new patient, but in elderly patient. So the question for me is to create lower canal nerve paralysis over 50 years is a big problem. So I try to avoid. This is not to perform exactly the age. It's a functional result. If you create lower canal nerve
पानी नहीं डाल रहे हो यार. देखना कितना.
It's a terrible trouble for the patient for the long time, for all the life.
Diamond.
So the tumor surrounding these
Hello.
you would like to preserve, you would like to keep it as it is.
Hello.
No. Because this lower canal nerve is involved, you have to operate. This is solves the problem.
Bye.
Only once you have no partial lower canal nerve function disturbed,
Hello. Cotton bol rahe hain.
Yes, sir.
Hello,
Yes,
yeah,
sir.
yeah, we can hear.
Yes, can you hear me?
Yeah,
Yes,
we
sir.
can hear you.
See, this is the canal side, and what I have discovered, give me that diamond, more, bigger diamond. This is the sigmoid sinus. Can you see this?
Yeah, very clearly.
Look, pani mat dal. Yes, this is the sigmoid sinus.
Yes, sir.
Sometimes it is quite superficial, sometimes it is deeper. And today we will follow, like I showed in the end of the cadaveric dissection, temporal bone, how the sigmoid sinus forms the jugular bulb. The continuity of the sigmoid sinus forming the jugular bulb. Now this is the site of the mastoid emissary vein you can see here posteriorly. These veins are valveless and they are meant for equalizing the intracranial pressure with the extracranial pressure. Okay? So, in patients, suppose I am operating on this patient who has the opposite side compromised venous drainage because of a smaller sigmoid sinus or no sinus, whatever. So what I need to be careful is, I need to preserve this mastoid emissary vein, and for the closure of the sigmoid sinus, I need to go distal to it. Okay? So that I can preserve this blood flow going from the transverse sinus behind through the mastoid emissary so as to prevent the intracranial edema. Got my point?
Yes, yes.
So there are two other veins which are emissary veins which are acting as a sort of pressure equalizing veins are the condylar veins in the jugular foramen. The anterior and posterior condylar veins in the jugular foramen do the same thing. I will show you once we open the jugular foramen where the condylar veins open. Again, these veins connect the jugular circulation to the vertebral venous plexus. So what happens? If you ligate the internal jugular vein, that may not have that much of the effect on the intracranial pressure as compared to the ligation of the sigmoid sinus, the jugular bulb, because in the ligation of the internal jugular vein in the neck, these connections to the vertebral venous plexus through the mastoid emissary and the condylar vein remain intact. But while sacrificing the jugular bulb, you end up sacrificing all these connections to the vertebral venous plexus, and that cutting there, and that may result into high intracranial pressure. Got my point?
Yes, sir.
The resection of the jugular vein is much safer than the resection of the jugular bulb unless there is a good communication, the venous drainage on the opposite side. Now, to orient you, this is sigmoid sinus, this is tegment plate. I am excentrating all these cells. That's a part of the this subtotal petrojectomy. And now I am removing the extra-aortic canal skin. I will remove the entire extra-aortic canal skin and drill away the entire extra-aortic canal. The lateral part of the skin we have already removed. We have done the cul-de-sac closure to the lateral part of the canal. Medial part of the canal skin I am removing. And I will drill away this canal completely. I can do this with a monopolar without any issue.
Satish, do you remove the malleus and the incus as well?
Pardon?
Do you remove your malleus and incus as well?
Yes, I will remove not only malleus incus, I will remove the stapes suprastructure as well.
Okay. So Professor Manian, just a quick question again. You said we were discussing elderly patients and we were talking of lower cranial weaknesses.
Yes.
If we have a patient above 65 who already has involvement of a 10th nerve, what are we operating for?
In this case, I operate. If it was 60-65 with lower canal nerve paralysis, preoperatively, I operate and the follow-up is excellent. The main difference, when the disease induces lower canal nerve paralysis, it is progressive. So there is a rehabilitation and what we say, a nice recovery of the patient. But when it is due to the surgeon, is a sudden lower canal nerve paralysis, and there is never, in my experience, the rehabilitation is very poor.
No.
And the compensation is very poor.
Hello? Hello?
Yes, sir.
Yeah, Paramita, I am removing quickly the canal wall.
Yes, sir.
This part I am really quick because we know as a in our middle ear surgery we do this on a regular basis. So now I have reduced the canal down. Is this a magnification appropriate?
Yeah, this is right.
Is this good?
This is right. Yes, sir.
And see now what I have done. Can you see the malleus and the incus?
Yes,
in the attic. This is the part of the canal wall intact. This is some oozing from the canal wall, which I am going to use. Don't irrigate.
So Dr. Prakash Munka is asking what is the advantage of your conical burr and the rounded burr?
That is a faster burr, the bigger burr. For the outer areas, it is always a philosophy to use a biggest possible burr, which is much safer. Much safer. See now, what I am drilling is widening the canal all around.
Yes, sir.
This is part of the tympanic bone. And see the tumor in the extraordinary canal. See, this is tumor. Can you see this tumor bleeding?
Yes.
This is all tumor. So what I can do here, I can bipolarize the tumor easily. See, along with the tympanic membrane. Because everything has to go. No skin, the diamond. See now, easily the bleeding you can stop. See, for the bleeding control in otology and lateral skull base surgery, for bony bleeding coming from the bone, either you use a dry diamond or you can use a bone wax. For bleeding from the soft tissue like tumor, veins or any soft tissue, either use a bipolar or Surgicel. This is how you can control in the simplest way all the bleeding. Now see the rest of the canal wall left behind. Can you see?
Yes, sir.
This part of the bridge I am taking away.
Yes. So this is the question which many residents asked last time. What is the bridge and which is the ridge?
Yeah.
This what is removing is the bridge now.
And see, I am again like Prakash Munka sir asked. His question is so valid. Why the large burr? Because large burr is safer.
Yes. And the bridge of bone which is left anteriorly is the anterior buttress and the posteriorly is the posterior buttress.
Absolutely.
So I'd like to point out one thing what Satish is doing. You can all see this, he's bipolarizing the tumor wherever it's oozing from. And that's a very important thing because even if the patient is embolized, it does tend to ooze when your when your burr point tends to hit the tumor. And sometimes this oozing can be quite, blocking your way or...
Embolization is not a guarantee that it's not going to bleed. It will reduce, that's it.
Yeah, many a time you still do have
give me the right angle
encounter oozing from the
See,
tumor.
there is hardly any bleeding. There is hardly any bleeding and you will see throughout in the same manner, I will keep on controlling the bleeding. This is the malleus I have removed. Can you see? The incus I am removing. See, this is my facial now. See this?
Yes, sir.
And that is bare.
Yeah, it is there.
That is bare. Give me the diamond. Ek side choti.
There is there.
So quickly, I will now remove this buttress completely to widen the mesotympanum, and then we will move on to the facial now transposition. That is the key step of this approach. For the audience who are asking about the next webinars, we'll be having, we have planned number of webinars covering all the aspects on cadaver and live surgeries too, both. So like last week we did a cadaveric temporal bone dissection. This week we are keeping an extensive cadaveric endoscopic demonstration. From the nose, basic anatomy of the nose, to the in-depth anatomy and approaches to each and every sinus from all around. Like maxillary sinus, various approaches. Frontal sinus, various extended approaches including draft and modifications of the draft. And more importantly, the open approaches to the frontal sinus. Then various flaps for the paranasal sinus in the nose, which can be used for vascularized flap for endonasal reconstruction, skull base reconstruction. Then various areas around the nose like infratemporal fossa, pterygopalatine fossa, parapharyngeal space, their anatomy, in-depth anatomy of these areas along with the neurovascular structures and the approaches to these on a very, very good fresh frozen cadaver. That is amazing fresh frozen cadaver to see each and every anatomy in depth.
We are starting early, 10 or 11.
11 o'clock, yes.
So
that is the best
Sunday
time because we are dependent of that on the college. I am doing in the same college we did. It's not in our end. And then we'll move on to the skull base and a very important session on the anatomy of the orbit. In-depth anatomy of the inside of the orbit of each and every neurovascular structure and all the corridors to enter into the orbit to address the orbital lesions. Endonasal, external, intracranial, from all the aspects. So that will be the part one of the approach. That will be on Sunday. And after that, as I told you, we have kept a dedicated session on the facial nerve, full day workshop, and on the scabies surgery.
We have to cover benign lesion of head and neck also.
Yeah, one session, one webinar on benign lesion of the head and neck. Now see, where we have reached in the middle here, can you see the Eustachian tube there?
Yeah, very good.
Yes, sir.
That is Eustachian tube. Give me the surgery cell.
So will you burn the mucosa, the surrounding mucosa, the Eustachian tube opening, sir?
Yeah, see the Eustachian tube. See, I have elevated the tumor from the middle here. I pushed it inferiorly. Can you see very well? After coagulating it. See the tumor being coagulated?
Yes,
and
sir.
then for this small oozing you can use वो दे कॉटन बॉल देना यार मांगना पड़ता तेरे से गधा है say this cotton ball or the surgery cell to keep little bit of the pressure on the surgery cell to come into effect. Okay. Yes. So now you can see the horizontal portion of the facial nerve very well. Can you see very clear?
Yes, sir.
And this is the facial ridge now.
Yeah.
Now give me the cutting. That is the facial ridge. I will follow the course of the facial nerve from the horizontal to the second genu to the vertical and then to the stylomastoid foramen and from there out into the parotid. And we have to transpose it out. So again change to the cutting burr.
Yeah, people are asking, it is Sunday morning 11 to maybe 5:30 p.m. So it is Sunday.
Until it lasts. Yes. So that is going to be one of the most interesting part of the webinars. The endonasal anatomy on a fresh frozen cadaver. Right from the basic nose to the skull base with all surgical approaches and their clinical correlation at every step.
And all are requested to keep Thursday evening and Sunday full day off for next at least 3 to 4 weeks to finish the ENT.
Now can you see the kind of tumor coming out here?
Yes, sir.
See in the depth is the jugular bulb here.
Yes, sir.
And see this tumor coming out of the jugular bulb? Laterally here.
Yeah.
And this is where the facial artery runs, the facial nerve runs. So we have to now be careful. We have to see whether the facial is involved or not, because that is the most unfortunate situation when the pre-op facial is normal and the post-op patient present with a intra-op will come across with the facial nerve involvement. And this being a young patient, you know, I've already told my intentions.
But sir, as you mentioned, anyways, when you're lifting the facial nerve, you're separating its blood supply. So post-operatively, you will anyways have some degree of facial palsy
Yes,
that you said.
minimum grade 3 to 4, but I told you over the period of time, Diamond. Over the period of time, this improves, and in our series, majority of the patient, over 80% of the patient, they improve to grade 2. Give me drill. Funny. See now, this is the tumor which is come laterally by means of eroding the tympanic bone. See this bone in the hypotympanum, lateral to the jugular bone is tympanic bone.
Yes, sir.
We saw in the dissection all the 4 parts of the temporal bone. And this is the tumor which is coming laterally onto the tympanic bone, and this is how laterally it invades the facial fallopian canal and the facial nerve itself.
One question from Dr. Basart Naseem. What is your explanation for the ossicles not getting destroyed or dislocated by paraganglioma tumor?
Pardon? Pardon what?
Why the ossicles are not destroyed or dislocated in these tumors?
Paraganglioma. See, I told you it has a preferential path of spread and involvement of the structures. So this tumor, see the origin of the tumor is here now. Where we have to reach is this depth. All this tissue, all this bone lateral to it has to go, all this lateral to go, and then we'll communicate with the neck. Neck is here. See the neck is below and the jugular foramen is above. And above is the middle ear. So everything in continuity we have to expose to remove this vascular tumor. Now, give me bone nibbler.
Satish?
Yes, please.
Can you explain, the articles on partial rerouting of facial nerve and why it should be avoided?
Yes, yes. In limited, I told you, I mentioned earlier, Narayan. In limited involvement of the jugular foramen. Limited involvement means limited involvement of the carotid artery. We can take this call of partial rerouting.
This step, this you're removing it with Ronj.
Yeah, pakadna, suction rak. Now I reach to the level. Pakadna suction. I saw the facial now just coming out of the jugular foramen. As I mobilize this, I will show you. I will show you now. See, this is the last part of the, what is this? Tip. So I am pulling it towards me to keep it away from the nerve. See this? Completely out. And now I will show you my nerve. Shoulder. Can you see the facial now going out here?
Yes.
Can you see very clear or not?
Yes, sir.
And this oozing all around. See this vessel? This is part of the stylomastoid artery. See this? See this musculature? I will all separate this, and my nerve is below. See, my nerve is here. Can you see this now?
Yes, sir.
Very clear or not?
Yes.
This is the vessel right on the nerve which I am scared of. I am using slow bipolar. Give me a small diamond. See this now very clear going out?
Yes, Satish, see.
Yeah, and see there is a vessel which I am going to tackle. This is coming from the tympanic bone here. पतला देना है सेक्शन टिप फास्ट दिया कर पतला दे see this is the vessel, yeah, bone wax, little bit of bone wax. In order to control this vessel I should not traumatize my facial now. You have to be very careful. Okay?
Yes.
I will see to it later पेरियोस्टियम दे फास्ट. सो रहे हो तुम लोग यार.
So there's a question from Saudi Arabia. Dr. Moyad wants to know how close to the nerve you are safe to use a bipolar cautery.
It depends. See, once you are using bipolar, or for that any cautery, bipolar is being safe doesn't mean that it is a insurance. And see this tumor involving the facial nerve. Can you see here? This is all tumor. Can you see this?
Yes, sir.
This pure involvement of the facial nerve by tumor. Oh my goodness. I was scared of this thing. This poor chap should not have tumor involved. I told Professor, I just mentioned Professor Magnan, up to 10% of the patient having absolutely normal facial nerve function. Okay? They now have, up to 10% of the patient having normal facial nerve function preoperatively have tumor involvement to the level warranting the facial nerve resection.
So people observing the surgery should also see how he's controlling the bleeding, because managing the tumor, bleeding from the tumor, bleeding from the vessels, again, is the major thing in this surgery.
In this surgery, bleeding is an integral part of the, your entire surgical process. We'll see how extensively this nerve is involved, how much length of the nerve is involved, and then we'll take a call. Now see this nerve, as it comes out of the foramen, it ascends sharp laterally. See this?
Yes, sir.
Another branch. Yeah, give me. Oh. Yes, Pani. So this nerve is definitely involved by the tumor, and now it's time for us to take a decision regarding
So Satish, you're doing the extratemporal part of the facial nerve. Till where would you expose this facial nerve?
Till where?
Yeah.
Beyond the level of bifurcation, Narayan.
Why?
For transposition, I need to go beyond so that it remains tension free.
Correct. So if you do not expose a good part of the upper and lower segments, you would get your facial nerve pretty stretched.
Diamond.
Liable to injury.
Yes, I need to have a good coarse portion of the facial nerve to be swung anteriorly to enough length to prevent a tension-free, I would say, transposition. Now see, this is the second genu. You can see?
Yes, sir.
And this is the vertical segment, and see how the tumor is surrounding the nerve in the vertical segment. Can you see this?
Yes, sir. As we also saw on the CT scan.
Yes. The tumor coming here. My goodness. This is so unfortunate.
Professor Manian, you want to add something?
Professor Manian, would you still try to preserve the nerve? What will be your protocol here?
Yes, I will try to preserve the nerve because he's a man only 30 years old. We have time to create a facial paralysis, a total facial paralysis. I will try to preserve the nerve because there is some very small piece of tumor left at the end. I am sure you are able to do that.
Satish, are you using facial nerve monitor over here?
Yeah, we have. But see, what will it do? See this. The decision to preserve the nerve or not is based on the extent of involvement, boss.
Yeah.
Of course.
Yeah, see, nerve is infiltrated by the tumor. Can you see this?
Yes.
Professor Magnan, can you see the nerve is infiltrated?
I see the infiltration, but there is
Would you still preserve this nerve?
I will try, yes, definitely.
You will still preserve?
I will try to do that, but you are the boss. I am not.
See the kind of nerve which is involved by the tumor here. Here
Yes,
deep is the, in the depth is the, see the jugular foramen is in the depth.
Yes, but the fascial function is normal, you told me. So I will try to preserve this.
And see, there are a lot of studies done in this regard. To predict the pre-operative involvement of the, predict pre-operatively the involvement of the facial nerve. So what do they say? That get the electroneurological studies done, electroneuronography pre-operatively, in spite of a normal functioning facial nerve, in spite of the normal nerve, if you have the neurons working less than 50% as compared to the opposite side, you may imagine that facial nerve is seizures involved by the tumor in spite of a normal functioning nerve.
Satish,
yes.
It's a good time now to talk about partial rerouting and why it should not be done.
Partial?
Partial rerouting.
Partial rerouting in this case is out of question. I told you beginning several times, when the vertical petrous carotid is involved, that rules out all these things. Scissors dena.
Are you planning to sacrifice?
I am evaluating. I am trying to lift it off.
Okay, so let me give the answer. I don't think Satish has given the answer. We do not do partial rerouting of the nerve. Okay, partial rerouting means lifting up, like what is showing, up to say the second genu, and trying to remove the tumor below it. We don't generally do that because the nerve, if you see, if he partially reroutes it, it's still liable to stretch and injury. So whenever we are dealing with these tumors, it's always a good idea to do a complete transposition of never a partial transposition. That's what I was asking Satish.
Okay.
I fully agree about this comment. Partial rerouting is more dangerous than total rerouting.
I have a question.
See Narayan.
Yes, Satish.
This portion of the facial nerve above this is normal?
Yes.
Yes.
Below this is normal?
I am sure you can preserve. I am sure.
And this portion is infiltrated by the tumor. You can see.
Yes, but you preserve. Is a benign tumor.
Yeah.
Yes.
Sir Manion wants it to preserve.
Want me to preserve?
Yeah.
Because it's
Professor Manion,
yes.
Would Professor Mario Sana preserve this now?
No, but Jacques Magnan, yes.
Cotton ball. Cotton ball.
It's nice to have varying opinions and so much of experience all talking, so people know about the controversies in the management of the facial nerve.
Yes,
it's nice.
Facial nerve.
It's not really good to agree with each other, right?
Yes. Yeah. See now, I have separated this portion of the nerve or the cotton ball. See this? I have separated this portion of the nerve.
Yes, sir.
I have not sacrificed yet. Let's see. Though my gut feeling is to sacrifice this now. I tell you.
Dr. Rajan Bhargav is asking why not to do stereotactic on remnants of the nerve.
Why not to do?
Stereotactic for a small remnant on the nerve, facial nerve.
But this is no longer going to remain functioning. Why to preserve? The issue is, will it remain functioning? What do you think?
See, when you do stereotactic or any other mode of radiosurgery on the remnant on the nerve, okay, the tumor contracts, and that itself will cause facial nerve weaknesses. So it's not causing facial nerve weaknesses post radiosurgery. It's rather you cause
the facial nerve. Everywhere it is bleeding like anything.
Okay, so no radiosurgery. Either you leave it there and forget about it, or then you operate it. Would you agree, Professor Manian?
No radiotherapy, no gamma knife, nothing else. Only you scan the patient. You follow the patient to see what happened on the remnant. But in many cases, nothing happened. So,
yes. Yeah. So that's what we are driving home. No radiotherapy, no stereotactic.
no complementary radiotherapy. No. For the piece of tumor is 1 to 2 millimeter. The risk of facial weakness is increasing.
So like Professor Manian says, if there is a residual tumor in any case, it does not mean that you have to jump in and do surgery, whether it's on the facial, whether it's on the carotid. You may get a residual tumor at any point in time, but you would rather observe these patients rather than jump into surgery or offer anything else. Only if it's growing do you need to think of resurgery. Yes, you would probably observe this patient for life. It doesn't really matter to you.
As I mentioned, boss, as I mentioned during the course of the elderly patient management, it is post-surgery also, if whatever tumor you have left, serial imaging has a role.
Correct.
If the tumor is growing, then you have to do something, otherwise nothing.
Exactly.
So how often will you do a CT or an MRI?
You go to the Mario Sana's protocol, 1, 3, 5, 7, 10 years.
Yes, I know.
Yes, good.
Yes.
Satish, 1, 2, 3 and 5. 1, 2, 3, 5, 7.
Yeah, he followed till 10 years.
Yeah, I understand. It's not 1, 3. It is 1, 2, 3, 5, 7.
There are many people are recommending, including Dr. Abhilash Alex, why to sacrifice the facial nerve for the benign reason. There's so many people are recommending.
Deepak Dalmia is requesting you to preserve it.
Yeah.
Sir, I wanted to ask, now this is anterior transposition. In which cases will you do a posterior transposition of the facial?
The posterior transposition is required in transcochlear approaches.
Yes, sir.
Yesterday we did a huge clival chordoma with a transcochlear approach. I mentioned in the, in the temporal bone dissection, both the techniques and indications of the transposition. So in posterior transposition, you cut the GSPN and rotate the nerve posteriorly. Simple. Now, can you see the divisions of the facial now?
Yeah.
Like Narayan asked how far you will go. I go little more than what people recommend.
As far as possible.
Yeah, but definitely not shorter. That's the message we are trying to convey. If you do it lesser than the divisions, then you're going to have a severe stretch on the facial nerve. It's not easy to transpose. So that's the message we are trying to convey.
Suction. See, once we transpose this, why we are transposing again for everyone? See this, below this facial nerve is our tumor jugular foramen is so deep here. Once we take this facial nerve away from here, we will be right on the jugular foramen, then we'll come from the neck below. We have already opened the neck. See, this is the neck here, all the great vessels here, and this is our jugular foramen. The moment we remove this bone, this tympanic bone, after removal of this facial nerve here, our area of the jugular foramen will be open for dealing. You can do anything.
Better exposure.
Yes. चल क्यों नहीं रही? नहीं चल अरे हट. तीन जने हो तुम लोग ना?
So Dr. Krishna Das from Bhubaneswar is asking, can we do a facial reanastomosis in this case?
Yes, we have many options. If you ask me, the best option for this, if you ask me, see there are difference of opinion. And no one is, everyone is right. The option to me, which I would like here, is to do a fasciomesenteric anastomosis by sacrificing this. That's it. And my masseter now works like, the fastest source of reinnervation. Fastest source of reinnervation to the facial nerve. Results are amazing. And it is close to the, I would say, spontaneous smile. Though spontaneous smile can only come when you get the discharge from the facial nucleus. But I told you, close to the spontaneous. So mesenteric I like. people don't do, I don't know the region, maybe difficult to identify the mesenteric. But I'm regularly doing the mesenteric, which is the choice of nerve for anastomosis. See the facial now, all the way. Give me the bone nibbler. Beyond the bifurcation. See the facial now being elevated, this one going up. Mop.
Yes, sir.
I will show very clear. Let me remove part of this tympanic bone here, little bit. No. See, mobilizing the tumor. There is tumor underneath. Can you see this?
Yes.
There is, there is just tumor underneath. See this? This tympanic bone is right over the jugular bulb. And this is all tumor underneath this, and this is the facial nerve which is entangled. इसको पकड़ना ही हो, इसको पकड़, पहले मोबिलाइज नहीं हो, इसको पकड़, इसको पकड़.
So you see, he has to take a lot of care. His facial nerve is very close proximity, and that's a loose piece, bit of bone.
Yes.
A lot of care to preserve the facial.
And this may open up the jugular bulb as well. See this bone? See this remnant of this bone is still left.
Yes, sir.
See lot of tumor deep to the facial now. See lot of tumor deep to it. बड़ा दे, थोड़ा बड़ा दे.
Professor Mani, would you do anything different or some other tips that you would like to give?
No. I go on for the transposition, anterior transposition, and he's doing a good job. He's in a good way.
So first of all, I will transpose this now, like Professor Manian said, and then we'll come to this area so that we can tackle this bleeding in no time. No issues. So what I will do, give me a smaller one. Patla de. So transposition, what all it requires is, see this under magnification, I will go on to the anterior genu of the nerve. Hata.
Yes.
Idhar se pakad.
So we have to remove all possible bony spicules anteriorly so that they will intend
that may traumatize the nerve otherwise.
Yes.
See, this bleeding is because I mobilized the tympanic bone and the jugular bulb started bleeding. That is usual.
Yes, sir.
Just a minute, Chode. I'll just peck for a minute, it will stop. No time, it will stop. No time.
So I think the message we would like to convey is use Surgicel and try to get the bleeding a little bit under control, rather to work in a very bloody field where there is more chances of injury to the facial.
Yes, you have to be ultra careful, no? You're right. What I'm trying,
Satish is extra careful, but for lesser
I'm trying to stay the same. See the minimized.
Yeah. So what will happen if we leave the tumor around the facial nerve? How much time the chance of regrow will be there, or after how much time?
Every tumor, every patient has its natural course of, tumor growth. You never know. But in young patients, it is not advisable.
Okay, maybe Professor Mani could answer this because he's talking of leaving behind tumor.
See now the bleeding is almost stopped.
Yeah. So what are your long-term results when you observe these patients who have left behind residual tumor on the patient? What are the long-term results or what are the long-term sequelae of these patients?
You must follow the patient all the life, in fact. Because I saw some patients, there is some regrowing after 12 years. After a small piece of tumor, it was a humidity, and I have to go back 18 years after.
Patli diamond.
Follow the patient all the time. And what he was saying, it depends on the patient. The potential of growing is so different from one patient to another one. I follow some patient with it was a partial removal for a big tumor, and I follow the patient all the life without any other.
Curate भी रखना, side knife भी रखना. देना यार.
is individual.
पतली दे यार, ये बहुत मोटी है के लिए. Hello.
Yeah.
Yes, sir.
Now I am at the anterior superior edge of the cavity.
Yes.
See the toward the geniculate ganglion.
Yes, sir.
And my facial will come from here. From a new, I will create a new fallopian canal.
Yes.
New canal for the facial nerve. And fix the facial nerve on this side with a tissue glue.
What are the chances of converting to malignancy? Let's suppose we leave there's some tumor inside. What are the percentage of theoretically or your experience?
Yeah, by and large, 5 to 20% of these jugular paragangliomas that turn into malignancy. For malignancy, mostly those who have SDHB mutations, they turn into malignancy.
Okay.
The diamond there.
I think what Satish was mentioning was in the general population, but if you're leaving behind residual tumor, then none of these would have really malignant transformation. Not that I would see anything having malignant transformation.
Yeah, it's not so common.
It's not so common.
So when you place the facial nerve back, what additional what will you do to give blood supply to this nerve? When you place the nerve back after you're done.
Back means back to the same place.
Yeah.
Huh?
It exists.
No, why?
No, I am shifting to a new place. Why back to the same place?
Okay.
Pakadna.
So Satish, Dr. Vinod Felix is asking.
Yes.
Really confused on how radical to be while operating on glomus. Lot of controversies on handling tumors.
Yes, very clear. That's why I mentioned in the beginning, there are so many factors to be taken into account before taking this decision. Age of the patient is a very important factor. Number one, I tell you. If younger patient, you have to stay radical, because in younger patient, in younger patient, even if you give lower cranial nerve palsy, the chances of compensation are very good as compared to the elderly. By and large, in elderly patient, you have to stay more and more conservative. And if tumor shows growth, you can take a call of radiation. Sometime a partial removal in case it is compressing somewhere. Okay? Debulking or subtotal removal, whatever you can say. But in young patient, the trend is towards surgery, because surgery is the only cure to these patients. There is no other remedy. Lots of treatment are being investigational. At the molecular level, targets are being defined to control this tumor. Like for example, the imatinib is a monoclonal antibody being tried. Lot of trials have been done to find the role in this tumor control, glomus, the paraganglioma. Then somatostatin analog. These tumors have extensive somatostatin receptors, and those analogs are being tried as a future remedy, as a medical management of these tumors. Got my point? But by and large, your surgery is the only answer so far. So in young patient, you have to stay radical. That's the GSPN you can see going anteriorly.
Yes, sir.
See, this is what I am doing, what Paramita was saying, to remove all bony specula. Yeah, that may press on the nerve and the entire purpose is defeated.
Okay, Satish.
Yeah.
I just got Professor Manian, I got a call from Dr. Morwani just now. He says that, exactly as Professor Manian was saying.
Morwani sir was about to join. Has he joined us?
He's listening probably. He just called me and he passed on a message that just as Professor Manian was saying, you can actually take out the sheath of the nerve without actually damaging the nerve.
Why did he join so far?
take the perineurium off and leave the nerve filaments intact.
What? Can you repeat what he's suggesting?
He said that whenever you have tumor on the facial nerve, you can attempt to take off the perineurium, okay?
Yes.
Of the nerve and try to retain the nerve filaments intact. That's what he's passed on a message. Exactly as Professor Manian, you would try your best to retain the facial nerve intact.
I got your point, but see, Narayan, to me this is obvious involvement of the nerve.
Yeah.
This is not, I would...
he also does exercise, but he just asked me to pass on this message that he would make an attempt to probably, take off some...
And you have got the answer from Professor Manian. I asked him, if this case was being done by Professor Sana, what would he do? He said he would sacrifice. Straightforward. Let me release some more now. Can you see this? I have not released much beyond the bifurcation. Can you see, Narayan?
Yes, Satish.
Over there.
Satish, now that you have transposed the nerve, can you show the area of infiltration once again?
Area of?
Infiltration of the nerve.
Yeah, I will show again. Let me free it from the bed. Scissors. See, this tympanic segment of this nerve is quite flimsy, There should not be any traction on the tympanic segment at all.
Yes.
Now break the nerve completely.
Deepak Dalmia is asking, what is your indication for observation and contraindication for the surgery? For this surgery?
For this surgery?
Yeah.
Yes. Contraindication, like I told you, elderly patient.
Yeah.
Patient who are unfit.
And besides medically unfit, surgically.
Yes. Surgically, elderly patients. That's it.
Okay.
And patients who have a opposite side cranial nerve palsy, I would think twice before operating. If the patient has opposite side lower cranial nerve palsy, I would either observe, would do a partial resection a little bit, preserving the lower cranial nerve, or I would radiate. See, those are the situations where you have to think twice before doing any radical surgery. The patient has opposite cranial nerve palsy, you can't. Got my point?
Yes.
Due to tumor on the other side or any region. Palsy on the opposite side. Now I will fix this nerve on this side. The course of the facial nerve in the parotid also is very funny.
Yes, sir.
Okay.
In your surgical practice, which stage you get?
Give me over there. Surgical there. Pardon?
In surgical practice, which stage you get maximum cases? Like stage 2 is.
See this? I am fixing this nerve here again.
Yeah.
Satish?
Yes,
are you planning to do a resection anastomosis?
No, boss, I have now transposed. Man, you are asking now.
I'm just asking you because that's what you were mentioning all along, right?
See, Narayan, what you have been... See, this part of the nerve you were seeing?
Yeah.
It is involved. Can you see, Narayan?
Yes.
Narayan, what is your gut feeling? This part of the nerve. See this?
Yes.
Tell me, man. Go there. Surgical though. Narayan.
Yes, go on, Satish.
This part of the nerve, look at the condition.
Yeah.
What would you do?
So, from here, what it looks like, you could probably get a plane. But I mean, I'm sure you have a better view on under the microscope.
Now you are getting microscopic picture. Why are you being so diplomatic?
Diplomatic answer.
You would ideally want to resect it off, but if you feel you're resecting too much, you may as well do a complete resection anastomosis and grafting. It's simple.
Pardon? Resection anastomosis?
You should resect anastomosis, right?
They? Abhi surgery cell they are.
In fact,
see now this is jugular bulb. See now this is jugular bulb.
Yeah.
And now I will handle it effectively as I lifted the nerve from here. Okay? दबा के रख इधर. यो रख ले. See my nerve running anteriorly. Can you see?
Yeah.
Narayan?
Yes, Satish.
Can you see the nerve anteriorly? Very small surgical, very small. Can you see the nerve running anteriorly or not?
Yeah, very clearly. One comment from Dr. Deepak Dalmia.
Yes, Deepak.
Since vascularity is already gone for the tumor, so if we leave some tumor around the facial nerve, then what is harm? At least we can give a few years of facial.
The prospect of functioning such facial nerve are not good. If the facial nerve functions well, why would I am not crazy to cut the facial nerve unnecessarily. See, I have put some tissue glue to keep the facial nerve in place. See this?
Yeah.
So with my future working, this will not come in the way. Okay?
Yes, sir.
So I pushed the facial nerve on the other side and kept some glue over it. Okay. Yes. Now, aajo.
Sir, there is a message from Dr. Sunil Dutt from Bangalore. He's saying that he's thrilled to watch your work of art turning into a masterpiece. And he agrees to Professor Manion, and he will also like if you would appreciate and preserve the which you have done already.
See, there is a tumor in the jugular bulb.
Yes.
Now,
your audio was cut actually. Repeat it again. What you were saying?
I'm saying there is a message from Dr. Sunil Dutt from Bangalore. He's saying that he's thrilled to watch his work of art turning into a masterpiece, and he agrees to Professor Manion about this decision of preserving the nerve.
Oh, great. Well taken. Thank you, boss. Yeah. Now, coming back to what we did in the neck and where we are now. Now, see the neck. Can you see now?
Yes.
The previous area where we dissected in the neck, you can see the structures, the carotid artery, you can see the internal, external, the jugular, the nerves you can see, and here is the jugular bulb. Now, what I am going to show you is, yes, now with this, we'll uncover the great vessels right up to the level of the jugular foramen. See this. This is all the muscles behind which I am going to coagulate. Bada dissection.
So now Deepak Dalmia is full form. He's in full form now. He's asking the same thing. What you will do for the pleomorphic adenoma, involve the facial nerve in parotid and nerve is normal preoperatively.
Yeah. Will preserve. See, in parotid, and the same question arises in the thyroid, in well-differentiated cancer.
Yeah.
These cancers do well with the adjuvant therapies. So we should shave off the nerve, shave off the tumor from the nerve. Even if you leave a micro tumor over the nerve, can be taken care of later without affecting the survival much. So there the situation is different. Now, having removed this tympanic bone, not completely, partially, see this?
Yes.
What is this structure which is going down in the neck now? This is styloid process.
Correct.
Styloid process is the anatomy. See, this is styloid process. Is the anatomy monopolar, which runs lateral to the great vessels. That's a great landmark. Section. Great landmark that you are lateral to the great vessel. Can you see the height?
Yeah, now we can see.
This is part of the external carotid. Pakadna, pakadna, pakadna.
Wing?
Yeah. Pakadle. The part of the external carotid branch running in the parotid. Ay, pakadna. ठीक है.
You can see Lehman actually.
Yes. Fine डालिए अगर साफ कर. See now the styloid process coming into the picture.
Yeah.
That's the part of the external carotid which was running into the parotid gland, you know.
Yeah.
Take gloves, sir. And we'll ligate this branch rather than leaving it. Now very soon we'll be on the jugular foramen. In next 20 minutes, we'll remove the tumor. Half an hour. We have to do closure of the sinus and all that. Professor Manian, you are free to comment any point of time. Free to share anything you want to.
I have the pleasure to see you and to see your
Thank you.
subject.
So this is, see, this is your styloid process, and these are the muscles attached to the styloid. Can you see?
Yes.
The three muscles which are attached to the styloid, you can see here. And this styloid, as I mentioned in the dissection, is a part of styloid complex of the temporal bone, which is extratemporal structure. Section रख यहाँ, bleeding होगी, वो भी रख, सजी सेल रख, दो section रख. See this, completely out.
Yes, sir.
This styloid and the base of the tympanic bone is out.
Yes, sir.
So now this will further uncover the jugular foramen. Jugular bulb containing the tumor. This is the area of the jugular bulb. Now our facial nerve is away. See this here.
Yes, sir.
So we are able to deal with this jugular foramen region so effectively. Since we have taken the facial nerve away from the area lateral to the jugular bulb, that is so difficult otherwise to deal with such a vascular tumor.
So Dr. Pawan Singhal is asking that doesn't the tissue glue compromise the blood supply to surroundings of the facial nerve? The tissue glue, does the tissue glue compromise the blood supply?
No. This is time being. Not at all. Not at all.
So Kumar Swami is asking from Bangalore that if there is a rudimentary or a non-dominant venous system into the opposite side, do you operate?
What rudimentary?
If there is a rudimentary or a non-dominant venous system on the opposite side.
What opposite side? What structure? Venous system.
Yeah, venous system.
I mentioned you have to be extra careful. You have to block the, keep the emissary vein intact. Then your options are different. In that situation, your option number one is to wait and watch until it is deemed to do. Number one. Number two, if you are doing, you can do a partial work preserving the jugular system. Section. Partial work preserving the jugular system. I am just removing these muscles over here to remove the structure from behind the jugular foramen. Okay?
Yes, sir.
My jugular foramen is here. My facial nerve was going from here. This is tumor. It's all tumor. So I will clear this area thoroughly now. This is cleaning the area behind the jugular bulb. And I will remove this part of the occipital bone, part of the jugular process of the occipital bone here. Drill.
Vertebrate from here.
So for everyone, for orientation, dissection.
Yes,
See,
sir.
my jugular foramen is here. See, my jugular foramen is here.
Yes, sir.
With tumor there. For your orientation, this is lateral semicircular canal. This is lateral canal. Everything is removed from here, and this is neck. Tetwa, ye kahan se aa raha hai?
Did you remove the suprastructure? Many are asking.
I have not seen yet. If there, I will remove it before obliteration, and I use here because this is going to be a mobile suprastructure. So I have my laser connected. I will remove immediately.
Okay, sir.
See, now I am removing this bone behind the jugular foramen. Can you see this?
Yes, sir.
Yeah.
I told you that time the rule of 1 centimeter from this base of the mastoid. If you go 1 centimeter down and 1 centimeter deep, you may come across the vertebral artery.
People want to see it.
Vertebral artery.
People are willing to see it, vertebral artery.
Come on.
Dr. Gul Motwani wants to see it.
That will be shown, I think, on coming Sunday.
So daring, madam, so daring. Want to see the vertebral here? First of all, it is need not to be seen, number one.
Yeah.
You need to know where it is, the course, where the course is. Secondly, yes, in tumors where it is involved, then you have to additionally use a extreme far lateral approach. Then I would remove these muscles attached to the this lateral process of the atlas and discover the vertebral artery and remove the tumor around it completely. That is a different thing.
On Sunday we will show it, no problem.
In routine, need not to be seen.
No.
See, this is all tumor which I will remove later. Preparing the diamond there. All this is tumor. I have to anteriorly separate the carotid from the tumor and then I will start removing the tumor.
There is one question from Dr. Amit Keshri,
Yes.
Dr. Narayan. Any incidence of pinna necrosis after post-embolization, especially done in post-auricular artery, supposedly?
So we have never had a case of pinna necrosis.
But it has been reported, Narayan.
Reported yet, but we have never had that.
See, all these are inherent complication of inadvertent embolization.
Yeah.
To the areas which you don't want. See, I am following the sigmoid sinus further down.
Yeah.
But let me have put it reversely, Satish. One case or few reported cases of pinna necrosis does not mean you stop doing the embolization.
No, I am not saying that.
Yeah.
What I am saying, inadvertent embolization, for that, your intervention radiologist should be very good and we should be able to pick up the dangerous anastomosis.
Correct.
And we should use nowadays onyx.
Yes.
Onyx
and it
is a
selective embolization of vessels.
Onyx is a liquid embolizing agent which is not affected by the flow of the blood. You know?
Yes.
And it goes to the tumor microvasculature. See what I am removing? The part of the condyle.
Yes,
Yeah.
Behind the jugular foramen to expose the posterior medial inferior part of the jugular foramen. This is jugular bulb.
Yes, sir.
Before doing anything to it, I am exposing it from all around.
Yes, sir. Sir, can you just show us glossopharyngeal nerve?
I will. As I go anteriorly, I will. Once I go to...
In fact, all the cranial nerve actually.
Yes. I will show, definitely. And probably I will show the branches also from the glossopharyngeal, if possible.
Yes, sir.
I will show the carotid nerve which arises from the glossopharyngeal inferiorly. And the Jacobson here is gone. Otherwise would show the Jacobson which arises superiorly. See this glossopharyngeal as it comes out of the jugular foramen. In the foramen and below it gives two branches. The one goes up toward the middle ear, that is Jacobson's.
Yes, sir.
and one goes below, that is to the carotid body, that is carotid nerve. Saaf kar. Diamond.
Satish, at what point do you uncover the sigmoid sinus?
What point?
What point? Are you doing it now?
Not now. I will first expose the carotid. At the end of the procedure, I will do that.
No,
I mean, just before, my
exposing.
2 steps would be just before tumor removal. One would be the...
Satish,
Yeah.
I'm not referring to blockage of the sigmoid sinus. I'm asking you exposing.
Exposing.
Because for a younger individual, it may be a good idea to keep the sigmoid sinus in view with the bone over it uncovered and the jugular point in view. Suppose a
See,
person...
the sigmoid is in view all the time. This is sigmoid.
Yeah.
What do you mean?
Not
Chota
with the bone uncovered. That's what I meant. The bone over it has to go.
Bone, I will remove that.
Yeah, you eventually will, but it's just a good idea to do it a little earlier. That's about it.
See, this is the posterior to the jugular bulb. This bone I have removed. And this is a very good idea to, once I go inside the sigmoid sinus, this will expose my posterior-medial part very well. Now, coming to the critical area. This part is okay?
Yeah.
Yes, sir.
Is this clear? Now give me some Surgicel and then pack. Some Surgicels. See, there is hardly, the field is good, no bleeding. There. See, this little bit of the bleeding you have to be prepared with, you know. So, gauze rakh there.
Sir, Dr. Amit Kumar Rana from Bareilly is asking that after preserving facial nerve in such infiltrating tumor, can we give post-op radiotherapy for the remaining tumor?
We have already discussed, we'll observe if the tumor is growing. Indication is not by default, it depends upon the tumor biology. So with the serial imaging, if we find the tumor is growing, we'll not think twice, as simple as that.
Okay.
See now, this periosteum at the level of the jugular foramen. Now see. Now coming from the neck, can you see the nerves?
Yeah.
Look at the cranial nerves. These nerves come out from behind the medial wall of the, deep to the medial wall of this jugular. This is jugular, can you see? All nerves are coming from behind. So important to preserve all these cranial nerves. If you keep the medial wall of the bulb intact, your nerves are automatically preserved. Got my point? That will be our main philosophy behind preservation of the nerve, unless the wall itself is involved, then we'll take a call. And in this case, if they are involving the cranial nerves, I'll not think twice now. Now see the internal carotid artery?
Yes.
See the loop of the vessel?
Yeah.
There are loops in the parapharyngeal internal carotid are so common. See the loop?
Yeah.
Can you? Retractor लगाना. Try to इधर आना यार. No, not 12th.
Thickener. Very thickener.
Yes. See, that is the 12th now.
Yeah.
That is 12th now. And that is most likely our glossopharyngeal. Let me confirm. There are two nerves which go one above another. Anybody can name at this point? Two nerves parallel to each other. Can you see these two nerves? Hello?
Yes, sir.
The upper one is glossopharyngeal and the lower one is pharyngeal branch of vagus. Hello?
Okay. Yes, sir.
These two nerves run together, parallel from below the jugular foramen. Rukna.
Satish, Kusum Patil is asking any role of radiation in any post-op, pre-op cases, like any role of radiation?
In these tumors?
Yeah.
So, Kusum madam, we have already discussed this fact. The radiation has an adjuvant role, though this question is very important.
Yeah.
Madam is from MP. I know she has been always been very, very keenly involved in academic activities. So for a question, the radiation has its defined indications. I have already mentioned, पानी डालना यार, हो रहा है, डाल. Yes. Yeah. So in case any residual tumor left behind, which is growing, in case there is any unresectable tumor, like suppose tumor infiltrating the brain tissue, tumor involving the intracerebral branches like ICA or PICA, tumor involving the cavernous sinus, you are left with only option, that is radiation.
Is it really effective?
Pardon?
Is it really effective, radiation?
Yeah, it obviously it induces fibrosis in the wall of the vessel supplying the tumor.
And again, she is asking what is the best way to assess the post-op recurrence or residue tumor?
Yeah, best way. I tell you, the best way is obviously MRI. But if you get this somatostatin receptor imaging, it has nowadays in the recent literature, that is DOTA imaging, is much sensitive than the tumor in finding the recurrent or residual tumor than the MRI, because of a lot of fibrosis there in that region. So now what I am doing here is, see the glossopharyngeal. Can you?
Yeah, very clear.
I am at the anterior end, just below the jugular foramen. See, this is jugular foramen, and from there, these nerves are coming out. See the nerve, glossopharyngeal.
Yeah.
So this is crossing the carotid. My carotid is deeper. This is what I am trying to trace out. Because I need to separate, we have seen on the imaging, this tumor is involving the posterior aspect of the carotid significantly.
Kumar Raja from Andhra Pradesh, he is asking, suppose other ear is also deaf, is a profound deaf, can we do implant in same setting? AI.
Yes, you can do. You can do if the cochlea, I told you the prerequisite for the implant that day, if you remember.
Yeah, I told you.
The fluid-filled cochlea, a fluid-filled cochlea and the intact cochlear nerve. If these two things are there, you can always implant. See these nerves crossing the carotid artery.
Yeah.
So here you have to be very, very careful in finding the carotid, following it up toward the skull base.
Once you're free, once again just explain how the carotid goes from the neck into the temple.
Yes.
Okay? Just
from the neck here, it takes a medial curve.
No, show it on the specimen.
Yeah, I will show the entire course, boss. What to tell, I will show. बड़ा लेना.
Even for today, for this uncommon case, very difficult case, still more than 5,500 people are logged in.
Oh,
right
really?
Now.
So crazy. So crazy. See, this kind of case, a lot of people are reluctant to do. I don't know, for the reason of fear of complication and all that. That's why we emphasize on more and more on the understanding the anatomy of this region, understanding the pathophysiology of this tumor, and the concepts of management. These tumors, any otology surgeon wishes to be work in a skull base can do it, believe me. See, what you need to do is a little bit of neck dissection like what we did here to follow these structures. Then in the temporal bone, obviously the anatomy of the temporal bone is important. See, now I am reaching the jugular bulb. This is jugular bulb here.
Yes, yes.
This is my carotid there. This is carotid there going. And this is the nerve which are crossing the carotid. Non-tooth. मैं मूव करता रहे. See this tough tissue at the level of the jugular foramen that you have to divide.
So for a beginner surgeon, I think this is the toughest area that they encounter problems because of bleeding. You try to use a bipolar, and you may get hold of one of the nerves, or sometimes while dissecting this tumor off or going to the jugular bulb, not knowing that anatomy can be very dangerous. So as Satish has already mentioned, the nerves come deep to the medial wall of the jugular bulb, okay, from their intracranial course to the neck. So they are deeper to the medial wall, and that's why he's doing this quite carefully, watching and taking out the tumor and the lateral wall of jugular bulb. Professor Manian, any tips that you would like to give people over here?
No. We have to dissect.
So now we are very soon reaching to the level of involvement of the carotid artery by the tumor, which I am going to separate. That is the most, I would say, the crucial part of the dissection, which I will show crystal clear.
It's very clear.
Yes. Yes. No, इसको इधर रखो. यूं. Sure ना. What I am looking at, the loop of the carotid, The loop of the carotid are always dangerous, See, see how they convert. That's the carotid.
Yes. That's why we are not disturbing you.
No. Carry on. Yes. See how the carotid is moving. This is carotid.
Yeah.
That is carotid. And that is the loop, yes. That is carotid. See this? No, ruk ja. This is carotid, And this is how I am reaching the level of the petrous carotid. See, this is carotid, very clear?
Yeah, very clear.
Satish,
yes.
You must give a big applaud to your people who are assisting you as well. Okay?
Yeah.
Exactly when to put in a suction, they know exactly when to irrigate and keep your whole field clean, due to which you're progressing so fast with your surgery. So your whole team, which is there, I hope they can hear us. Otherwise, you should give a big applaud to your whole team, the anesthetist.
They're used to all this.
Yeah, I know they're used to it, but still tell them.
Yeah, thank you.
One question from Dr. Dev Kumar Ranraja. So what is the reason for lower cranial nerve palsy post-operatively? Despite keeping the nerve structure intact?
The reason is this tumor, when we remove from the jugular foramen, when involve the medial wall of the jugular foramen, where the nerve passes, the nerve may get injured. in the medial wall.
Yeah. But how come they usually they recover after some time?
Yeah, it may recover. Now, you never know. It is not recovery, it is compensation.
Compensation.
Can I answer this differently, Satish?
Pardon?
Yeah.
Can I answer this a little differently
Yeah,
from what you're
yeah, please.
Post-operative, say you don't have a palsy, but now all these tumors are most often from the lateral wall of the dome of the jugular bulb. So when you resect the dome of the jugular bulb, we open up the jugular bulb. There's also inferior petrosal sinuses. So if you are very rough in trying to jam the Surgicel into the inferior petrosal sinuses, you could injure the lower cranial nerves at that point, where it runs deeper to the medial wall of the jugular bulb. Usually we leave the medial wall of the jugular bulb intact, and deeper to that is the lower cranial nerve. So very aggressive. Of course, Satish will show you that, how you have to identify the inferior petrosal openings and put Surgicel gently into the openings of the inferior petrosal.
Yes.
That's a very common reason why you get a lower cranial nerve weaknesses. And two, never try to strip off the medial wall of the jugular bulb, because that is definitely going to land you up in lower cranial nerve.
Okay.
पकड़ना इसको, ये पकड़ उधर वाले को.
Professor Manian, would you concur?
I agree about your comment. For lower canal paralysis is when you pack the inferior sinus is right. And one advantage of embolization, as sometimes the tumor is dense, you can put the Surgicel between the tumor and the medial wall. And this is a safe way to preserve also the lower canal nerve.
Narayan, Narayan.
Yes, Satish.
Can you see this carotid here, which is entering into the petrous portion?
Yeah, I want you to show that to the people, Satish.
See this carotid, this carotid, my internal carotid here.
Show them where the eustachian tube is to understand where the petrous is.
No. This is the where the entering into the petrous part, and see this layer where I am entering into.
Yeah.
Can you see this?
Yeah.
Yes, sir.
This is underneath the adventitia. See where I am dissecting into the. See this layer.
Yeah.
This is removing the tumor. This is tumor on the carotid. This is tumor.
Yeah.
Can you see this, Narayan?
Exactly.
I am separating in the subadventitial plane. Can you see very clear?
Beautiful.
Yes.
So this is what we commonly do when we are dealing with all these tumors which ascend along the carotid. This is the correct plane which you need to go and do it. If it's infiltrating beyond this, then obviously you need to think of stenting and other stuff.
This is playing with the carotid.
Yes.
And the carotid has got thick walls, so it's not very easy to damage the carotid at this point.
But not, this is vertical portion, you can say. But in the horizontal portion, you cannot do that. The horizontal portion of the carotid doesn't have adventitia, scissors. The horizontal portion doesn't have adventitia, and you cannot afford to do this kind of dissection there in the horizontal, scissors. Yes. See my entire course of carotid going up there.
Satish, if I could stop you 1 second, could you again show them carotid foramen, eustachian tube, and show them the course of the carotid, what you're doing?
Yes.
A lot of people need to see that.
Yeah, I will show.
Where the carotid would run. I know you're showing it.
I will show.
Show it now. Show the carotid after that.
Yes, okay. So far what I have seen, I'll show you the section. See this cervical portion of the carotid. See this after bifurcation. Can you see this one?
Yeah.
Yes, sir.
Okay, you rakh. Now after this loop, this carotid has come like this here. Can you see this?
Yes.
See this carotid?
Yeah.
See this carotid? That is the glossopharyngeal.
Yes.
Crossing the carotid, and see right, this is into the petrous portion, the upper vertical carotid. And then I will show you, once I go to the jugular foramen at this level, exactly the bony eustachian tube. I have not, see there is a tumor, so I can't show right now. But what I was trying to show, to separate the carotid from the tumor behind, because the tumor is towards the posterior wall of the carotid. No? You know, it was adherent to the posterior wall. See this?
Yeah, it's beautiful.
And see, I have separated.
How common is the vasospasm of the carotid artery?
Yeah, it can lead to.
How you prevent it, Dr.
You can use piperine. You can use piperine.
Okay. What you are doing right now? How you are taking care of this part?
Yeah, you can use xylocan, piperine. We have all these things ready. Our anesthetist keeps the things ready according. See the vessel completely now.
Yeah.
Can you see the carotid?
Yes, sir.
Clear.
Completely all the way free of the tumor from here. Can you see? The normal wall of the carotid. Absolutely normal wall, Narayan.
Yeah, we can see that.
And all these cranial nerves are here. See this?
Yeah, well preserved.
Yeah, my tumor is here, behind. See that? Now, before I start removing this tumor, I have to drill off all these bones also. All this entire bone I have to drill. And before that, I will now obliterate the sigmoid sinus from above. See the course of the carotid, so beautiful it is.
Yes, sir.
Absolutely free of tumor from here. Now, to obliterate the sigmoid sinus, a lot of people would take would take a suture over the sigmoid sinus, you know.
Yes, sir.
Take a suture on the sigmoid sinus. You can make an entry into the dura anterior and posterior to sigmoid and just simply take a suture needle. But that is something we don't do because that leaves the possibility of a CSF leak later. Those dural openings. So what I am doing is a standard, that is the extraluminal compression of the sigmoid sinus to obliterate it. And this is quite safe. See, I am making a window in the lateral wall of the sigmoid sinus using diamond, leaving a thin bone intact over it.
Okay, sir.
So out of your 200 plus cases, what is the incidence of lower cranial palsy in post-op cases?
Yeah, this variable was, you know,
and
the disappointment is when it goes unexpected. So the bottom line is, that is a lesson we have learned. In elderly patient, don't be heroic, stay conservative.
Okay.
Stay miles away from everything you can damage, you can say. Younger, I am aggressive.
Okay. And suppose...
Now see the sinus, the periosteum of the sinus.
And all recovered, or means suppose the case is not recovered, how you manage the post-operative aspiration? And
yes, lot of patients we have managed. So what happens? The problem is the aspiration, you know.
Yeah, aspiration.
The biggest problem is the aspiration, voice is secondary. That aspiration in the elderly patient can be fatal. So ultimately in many of the patients we had to do a sort of thyroplasty with arachnoid reduction and cricopharyngeal myotomy to reduce the tone of the sphincter, to allow the bolus to go directly down. See this?
Yeah.
All around?
Yes, sir.
Satish.
Yes, man.
Very well done. But suppose you do get bleeding at this point in time. There are a lot of junior people, of course.
Pardon?
How would you bleeding?
I get?
Suppose you
bleeding
get
at this time.
bleeding from the sigmoid sinus, how would you manage it?
See what I have done. See this long segment of the... See this? Sagittal.
Yes, sir.
This itself is good enough to prevent any problem. If there is any bleeding in the sinus, still I will package it. It will not embolize. So take a long piece of Surgicel. Packing is the only answer. See now, what I am trying to do, tucking my Surgicel underneath the bony margins. Can you see?
Yeah, extraluminal compression.
This is pure extraluminal. This will compress the sigmoid completely. And until it is not completely clogged, I will go on. All around under the bone. Jaldi mat kar.
As per Dr. Dev Kumar Rangraja, as per Mario Group published about 63% chances of new lower venous palsy. What is your take?
New lower vagal palsy?
Yeah.
Yeah, I told you we have a number of cases which we manage, and that's why we learned the lesson. In elderly, stay conservative. You can leave some tumor above the lower cranial nerve if it is invading, you know. If it is pre of functioning, leave some tumor over it and observe it post-op with the serial imaging. If it increases, if it starts growing, you can radiate. Secondly, for tumors which are asymptomatic and tumor invading the medial wall of the jugular bulb, still pre of function is normal. Wait until the nerves are paralyzed to compensate, you know.
Yeah.
The nerve paralysis on its own by the expansion of the tumor, slow growth of the tumor, will allow the time for the compensation to take place. So in that scenario, you can wait. I told you, the tumor invading the medial wall of the jugular bulb, not warranting with any symptom, any early resection, you can wait. And in that situation, if the nerve gets paralyzed, then it will not give any problem even if you sacrifice the nerve. A pre-op paralyzed nerve, if you sacrifice, won't result in problem, you know.
Yeah.
Abrupt transection of the nerve is a disaster, particularly in elderly people. So in glomus, there is a paraganglioma surgery, there are things on which our entire decision making revolves. So many things we discuss. Age of the patient, okay?
Yeah.
Natural growth of the tumor, involvement of the carotid artery, intradural involvement, lower cranial nerve involvement, facial nerve involvement, integrity of the collateral, venous collateral on the opposite side. Got so many things which need to be taken into consideration before decision making, and they are important aspects we need to keep in mind every time, every patient.
So Professor Nishi from Jaipur is asking, in your large series of cases, what is the percentage of involvement of carotid artery? Have you come
in
across?
jugular, almost all cases.
Okay.
Nishi madam has been my teacher, very favorite teacher. So, madam, for jugular paraganglioma, the carotid is almost always involved, we have found. That's why they have to be dealt with differently. Had this been a tympanicum, we would have been partying by now. See now, entire time, still we have not reached to the level of tumor removal, which soon we are going to.
Yes.
The entire time involved in exposure to the deepest anatomy. How deep it is. We took the facial nerve away, we opened from below, took the cranial nerves in control, the vessels in control, then we took the control of the jugular foramen. See, this is jugular foramen in the center, this is jugular foramen.
Yes, sir.
All around, see, it was so deep, now the tympanic bone, everything removed from above, the neck is in continuity, the middle ear is in continuity, everything, the facial nerve has been taken away. That is how these tumors have to be taken.
Yes, sir.
Okay? Then we took the control of the jugular foramen. See the jugular foramen in the center. This is jugular foramen.
Yes, sir.
All around. See it was shutting now the tympanic bone, everything.
क्या हुआ?
Late. So now finally what I have put is bone wax. See that? Just to ensure that my Surgicel overpacking will not mobilize. See. What do you believe? Is it effective packing? See
it's
the,
okay.
Yes, it is.
see the extraluminal packing. It is completely chalked. Completely.
You
See
will
my,
take out the gel, this bone wax later on, no?
yeah, the bone wax I will leave like this. And see now everything is fixed. See that's the Surgicel in place.
Yeah.
Completely immobilized after blocking the sinus so that it doesn't bother you anymore. Okay? Now, coming to the lower end, out of the jugular vein. At this point of time, the lower end of the jugular vein, see this?
You said you will be more aggressive in younger patient than elder patient. Why?
Yes.
Means they have better compensation or
Yes,
something else?
yes, obviously. Obviously. In younger, they have more life expectancy. If you leave a residual tumor, they have more chances of coming back with problem.
Yeah.
In elderly over 65, in such slow growing tumor, if you leave a little bit and follow, it may not warrant excision. So depending upon the lifespan as well. That's why age is a very important factor. Okay? Okay. Yeah, the same Surgicel. There's a question here that during mastoidectomy, the sigmoid sinus rupture, what to do? This is what I have done. Complete packing. In that situation, according to the need, no, you have to go. Apparent. Yes, yes. Chal, jaldi kar.
So what materials do you prefer for extraluminal packing? Like
Surgicel, Fibrillar. This is good.
Okay.
Yeah, but bone wax directly on the periosteum is not good.
Yes.
Now see, I have elevated this.
Dr. Vijay Chauradia is asking use of bipolar in close vicinity of cranial nerve. Does it affect the function?
Yeah, that is definitely good. See my cranial nerves here. My cranial nerves are here. Can you see this?
Yes.
His point is valid. The bipolar is always safer. So now I am reaching to the jugular foramen. Give me the diamond drill, please. A little bit of bone to be go. So now I am at the point of tumor removal now finally. To finish it off. Then we'll discuss what to do in difficult situation of glomus jugulare tumors. There are many difficult situations. Recurrent tumor, revision surgery, large intradural extensions, you know. Only carotid, opposite side, no.
Come back.
See now what I am drilling is occipital condyle. Can you see this?
Yes, Satish.
Yes, sir.
See the posterior aspect of the bulb? Oh shit. I am at the posterior aspect of the jugular bulb. See this jugular bulb?
Yeah, we can see that.
Can you see the jugular bulb?
Yes.
From behind?
Yes.
That's a proper jugular bulb, you know? That's a proper jugular bulb. Here, this is proper jugular bulb. See this? See this? Now, drill. Now, I'll drill. This is the semicircular canal, you know. That's why this patient has a sensory neural hearing loss. This is all Peter's bone which you have to drill until you get the normal bone. See the normal bone below?
Yes, sir. Not very clear.
See this? And anteriorly the jugular foramen, which I am reaching from all around now. See, this is jugular foramen here.
Yeah.
Now, give me the bipolar. I am at the tumor removal now. Now, we have blocked the sigmoid sinus from above. We have ligated the internal jugular vein from below. So now, what is the source of bleeding? The source of bleeding. See, this all tumor. See, this all tumor involving the cochlea. Can you see this?
Yes, sir.
See the cancellous bone here. See, I am pulling this. And this is the tumor going toward the Peter's apex. See this here.
Yes, sir.
This is the Peter's apex. See this region?
Yes, sir.
Give me a suggestion here. Oh, madal. So now what I will do, that was the area deep to the carotid. I will show you again once I remove the tumor thoroughly. This is all I can remove now. See, I am debulking it. I hope it is. Are you oriented?
Yes, sir.
Since a long time, Deepak Dalvi was asking so many questions to make it better, you join over here.
Hi, Deepak, welcome.
Deepak, unmute yourself. Hi, Deepak.
Yes, hello Rajiv, hello Satish, Paromita, and my dear
Morwani
friend
sir has not
Narayan.
joined yet?
So Deepak, I mean, just to clear your so many questions are there. Maybe better you ask and ask.
Yeah, Deepak, come on.
Actually, what Satish, you know, Narayan knows me better because we do with Sir and Narayan such cases in the beginning, and now what is happening, I always feel why you please don't take it. You may not like, even Narayan may not like, even Morwani sir may not like this question, that why we operate these cases. My question, Miss, I want to continue my question because sometimes I feel when the lower cranial nerve goes, can we operate then all such tumors? We can wait till now. Carotid involvement is a different issue, no doubt. But can we wait till lower cranial nerve goes?
Tumor I am cutting off, yes. I'll tell you, Deepak. Yes. Have you seen any tumors which have large interdural extensions?
Yes.
Given cranial nerve palsy on their own without operating. What will you do to those tumors? Tell me first. It is not the surgeon, it is the tumor which has given damage. This surgery we are not doing for our own benefit. This is evidence based. What else you can give to this patient? This tumor, if we leave it, this young patient, due to natural biology of the tumor, this will ruin everything. Now see where I am. Can you see this posterior surface? See this? The posterior fossa, posterior fossa plate. Now see this tumor involving this is fallopian canal where we lifted up the facial nerve. This is the cochlea which was, this tumor was, see this, the cancellous bone.
Yes, sir.
You never know in this marrow whether the tumor is not or a marrow. You have to flush it until you get the normal bone. See this?
Yeah.
Can you see?
Yes.
This is one of the commonest regions for so-called recurrence. Again, I always mention like inverted papilloma, like angiofibroma, this is benign tumor. They cannot recur once they remove. See now, the bone completely drilled off. Can you see the clear normal bone?
Yeah.
Absolutely. This is one of the commonest region for the so-called recurrence. Now, Deepak, I didn't embolize
Sir, can you repeat again which region is most common, sir?
this cancellous bone involvement.
Okay.
Hypertympanic bone, infralabyrinthine bone, bone of the cochlea, labyrinth. Now see, it is absolutely crystal clear. Can you see everywhere? And see the tumor, there is no bleeding. I didn't embolize this tumor, Narayan.
Yeah, I know.
Do you feel like embolizing? Would it make any too much of difference? Speak out from your heart.
Just a personal choice.
Speak out from your heart with this condition, operating condition right now. Is there any difference in embolized and non-embolized?
Satish, I have done non-embolization case also, and to be honest, I have not been that comfortable because the tumor comes out very piecemeal and really very soft. You know, in an embolized case, the consistency of a tumor, I feel, is much better.
Better, yes, that's what I am trying to say. Much better.
An embolized tumor, I said.
See now what I am trying to say. Separating the medial wall. Can you see this?
Beautiful.
Yes, sir.
Yeah. That is the most important part.
That is the most important part. See, idhar laga. See the carotid artery I have already left anteriorly. Miles away. Can you see this? This carotid. Hello?
Yeah.
Yes, sir.
These are cranial nerves. See this? And still there is a lot of source of bleeding left into the tumor because of the venous connections.
Yeah.
Section laga rahe yaar. See my cranial nerves going down?
Yeah.
All cranial nerves going down. See this. See the carotid left anteriorly, cranial nerve left medially, and I can remove the tumor after that.
Kusum Patikar is asking, this is very not uncommon. Suppose the other side sigmoid sinus is absent, then how will you go for this side surgery?
If I have already mentioned this, if you remember, if the opposite, I will take all these, I mentioned the difficult situations, after the end this, after the end of this. But to answer this, if the opposite venous circulation is compromised, not developed, taken away earlier, whatsoever may be the reason. Pardon?
Deepak.
Yes, sir. So you were saying something.
Yeah. So what I am trying to say, if the opposite venous circulation is taken over, suppose, can you see this bleeding from the inferior petrosal sinus? This one.
Yeah.
See these openings. Go, Sajisal there. There are 3 venous openings mainly. Anteriorly are 2. The anterior condylar vein and the inferior petrosal sinus. And posteriorly, where the sigmoid sinus turns into this thing, jugular bulb. See the medial wall of the jugular bulb now?
Yeah, very clear.
Yes, very clearly.
See posterior medial opening. What is this? Condylar vein. See this?
Yes.
See this. Let me show you. Venus. इधर लगा अरे यहाँ लगा ना हो गया सर्जिकल दे. So next 5 minutes and I am through. Then we'll discuss those difficult areas. But to answer Kusum madam, if the opposite venous circulation is not adequate, you have to be prepared for the eventuality if you are not careful. Number 1. See, this is the opening for the condylar vein. Can you see this?
Yeah, very big. Okay.
Deep. This is posteriorly.
Yes, sir.
Yeah. And see how effectively our sigmoid sinus packing was.
Yeah. Perfect.
इधर थोड़ा सर्जिकल दे दो. And see the flush wall, medial wall. See again the medial wall flush. There is no question of leaving the tumor behind. Do you agree?
Yeah.
Yes, sir.
So in case of inadequate venous circulation, you have number of options. First of all, reassess whether the surgery is deemed. If it is, you can do a sort of conservative surgery, leaving the jugular bulb intact. Dal. Number 3, and in that situation, you can follow post-op with radiation. Okay? Number 4, if you are doing, like I did the extraluminal compression over here, see this? Had there been opposite contralateral venous insufficiency, I would do this closure of the sigmoid sinus much distal there. Why?
Okay.
To allow the mastoid hemisphere to go uninterrupted. At least it will drain some blood. Okay?
Yes, sir.
And number 5, there are a lot of reports of reconstruction with the saphenous vein. You know, I will share some reports where the jugular vein, internal jugular vein from the neck, from here I tell you, from the internal jugular vein in the neck to the sigmoid sinus, saphenous vein reconstruction. You put 2 clips on both sides for a time until you reconstruct, and then once your suturing is complete, you remove the clip and the flow continues. And it works. So to answer madam's question, we have 5 options. Yeah, you can you can pass a carotid catheter so that you get time for suturing, adequate time for suturing, proper suturing.
Okay.
Now see, this is our carotid. Yeah, this is.
What is the frozen report of the lymph node? You got the
negative. I got.
Okay.
Reactive, only reactive. Sorry to. Has Prathamesh Pai joined us?
You can ask him.
I can ask.
No, he was supposed to. Maybe got late in Tata. So Prathamesh was supposed to join us, and you know all Prathamesh. Prathamesh is our dear friend. He is ENT guy who is consultant in Tata, and he, through his own efforts, started a dedicated skull-based unit in Tata for the first time in history. Amazing.
He is doing a lot.
Yes. So that is making us proud. See this? Now the carotid artery there. Why I am little conservative regarding controlling this bleeding here? See this? See all the cranial nerves. Can you see these nerves?
Yeah, we can see.
See this vagus nerve? I am not using any pressure over this. See this? Otherwise I may injure the nerves. So I will gently tease out this tumor and then pack that chota dena surgical.
Dr. Prathamesh Pai will join us soon.
Join us?
He will. He is joining us.
Cotton there. So they do a lot of skull-based procedures in Tata now. ये लगाना इस पे. See now, I am leaving some surgical over that inferior petrosal sinus opening. See this remnant tumor? See this remnant tumor? And I can remove this without any issues. Give me the scissors. The medial wall I can see very well. Section रख. See why I am little extra careful here is because of the inferior petrosal sinus. I really don't want to use too much of pressure over there. See this tumor out?
Yeah.
Yes, sir.
Now see the jugular bulb from inside. Amazing picture of the jugular bulb, you can see all.
Beautiful.
छोड़ दे, हटा इसको, छोड़ दे. Let the bleeding come. Give me small surgical pieces. Yes. See, these are the openings of the inferior petrosal sinus. See this here.
Yes, sir.
Gentle. You have to be ultra gentle. Right into the sinus opening. Not anywhere in the surrounding. See the carotid here. Find all way. See the carotid there?
Yeah, very clear.
This is subadventitial dissection. See this?
Yeah. Bare carotid.
And I am cauterizing this on the surface above. This is bare carotid. Now still a little bit of the work is left. See, the tumor is almost removed. Yeah, give me diamond bar. Diamond bar. This is last part. हटा दे छोड़ दे आने दे ब्लीडिंग आने दे
Professor Mani, do you want to say anything now? You want to
see now I am drilling in the vicinity of the bare carotid.
Yes, sir.
So this you have to be extra careful. दे यार जल्दी. See the inferior petrosal sinus bleeding a little bit. I am not bothered here for a minute. दे भाई. दे सर्जिकल दे और क्या देगा? दे ना. छोड़ दे छोटा दे कॉटन. See this bone?
Yes.
This was not good. Can you see this?
Yeah.
Yes, sir. Now it's
I am very, very close to the carotid. Now, the area which I was showing you, this one deep to the carotid. See this? This one between the cochlea and the carotid. See this?
Yes, sir.
This is petrous apex where I am going. See this? को देना यार सर्जिकल दे मेरे को दे फोर्सेप दे. See, I am working towards the petrous apex. रहने इतना नहीं छोटा कॉटन बोल रहा है. Asking again and again, very small cotton. See, to show you the clear picture of the petrous apex. Hello?
Yes.
That is the marrow bone of the petrous apex. I have reached to the limit. Can you see?
Yeah.
And see how deep I am to the carotid now. Now everything is okay. That is the region of the petrous apex. Very clear. Now see?
Yeah.
That area to be thoroughly assessed for any tumor which may be left behind. That is the region of the carotid. Now here the carotid takes a turn. Surgical there. See all these inferior petrosal sinus.
Bleeding it.
But I am tolerating them. I am not being aggressive, you know.
Two questions from Dr. John Shadow from Australia.
Yes, please.
When you transpose the facial nerve, so you put it you make a deep groove or full thickness groove to make it more secure, or just a half groove. So
what? Again, repeat.
How you make a new canal for the facial nerve? How much should be the depth of this new canal? That nerve should go fully inside.
Yeah. It's better to keep it inside and put a fibrin glue. See this?
And
I have kept this now. See this here, still.
Yeah.
absolutely away from what we are doing. See, entire surgery, we didn't bother about it. Can you see?
Yeah, we can.
This is the glue.
Yeah, it's working well.
That is the beauty.
And what need of suture around it?
Any need of?
Suture. Or its glue is more than enough.
Yeah, glue is best. See now the petrous apex region complete. Give me a suggestion here. So this is the carotid, and here the Eustachian tube is lateral to it, which I have drilled, and this carotid here takes a turn, anterior turn.
Yeah.
Like, let me tell you, bada dekh Goj. Let me tell you for a minute the anatomy here. See, the facial nerve ascends from the stylomastoid foramen like this, okay?
Yeah.
Here is the second genuine turn anteriorly, okay?
Yeah.
Same is carotid, run vertically, this is vertical petrous, then the genu, and then go anteriorly as a horizontal petrous. The course of the vertical petrous, the length is half than the horizontal petrous. Then anteriorly, 2 centimeter anteriorly, छोड़ दे काय को जोर लगा रहा है? 2 centimeter anteriorly, it takes a turn superiorly, intracranially at the level of foramen lacrum. Okay? I showed you on that sinus and that radiology session, that animated video of the carotid course. That foramen lacrum, it takes a upper turn to go intracranial. Now, this is the tumor which I told you, it is C2. Okay?
Yeah.
Had this tumor had gone infiltrating along the carotid artery till foramen lacrum would have been C3. And beyond that would be C4.
Yes, sir.
Okay?
C4.
Now, how would you address C3? What would I do? From here I cannot address anything more anteriorly. What I would do here, I would see this is TM joint. I would disarticulate the TM joint from this temporal bone above and push it down. Okay? And drill away this entire thick bone of the skull base, greater wing of the sphenoid, to go up to the depth of the carotid. The entire carotid you would see up to the foramen lacrum. That would be infratemporal fossa B. If you go further anteriorly towards the nasopharynx and the pterygoid, it is infratemporal fossa C. Pani there. And if you go beyond that, then it would go intracranial, that is D variety of the tumor. See now the entire tumor is removed. Can you see?
Yeah.
Yes,
Anybody, any doubts? Narayan?
No, good job, Satish. Very good job.
So, coming to the different approaches in case. Now I tell you, these tumors are so notorious, like Deepak was saying, why are you operating? These tumors, once they grow further, they grow deeper down into the clivus. See, the clivus is here deeper. Okay? If they go deeper to the clivus, to the prepontine area, they massively invade the intracranial area, then you have to go by the transcochlear approach. That is best. If they invade posterior inferior layer vertebral artery, you have to combine with a far lateral approach. If they go to any area of the lateral skull base, you have to combine with some or other lateral skull base approach. That's how the extended approaches are. That day, we saw the basic anatomy of the temporal bone. In coming times, we'll show each and every lateral skull base extended approach individually. Translabyrinthine, extended translabyrinthine, transcochlear variety ABCD, infratemporal ABC, middle fossa approach, transpetrous middle fossa approach, and the far lateral approach. So that will complete the dissection of the lateral skull base. Okay?
Okay, sir. Okay.
Yes.
Sir, your student Dr. Niteshwar is asking chances of carotid aneurysm or pseudoaneurysm after the subadventitious.
Yes, if you damage the wall, or if at some places the wall is inherently thin. See the carotid is nicely.
Yes, sir.
We have seen the carotid adventitia damage. In my practice, I tell you, I had 2 petrous carotid damage during this surgery.
Okay.
And in both cases, we could handle it. See now, everything is open, both hands. See this? Like open surgery. In both cases, we put the bulldog on either side and put a suture, A0 nylon, and it worked. One patient, we had a doubt of very small rent. So we put an aneurysm clip.
Okay.
Very small size aneurysmal clip, and it worked. So, carotid assessment, cross-flow assessment, and carotid management both are integral part of the management of this tumor. Now see, there is no bleeding at all. Professor Magnan.
Yes, sir. Professor Mannion.
See, these are all lower cranial nerves. Can you see?
Yeah, very clearly.
11th, see the 11th nerve here. 10th, this is 12th, this is 10th, and this is 9th here. This is 9th. This one is 9th.
Yes.
See this 9th. Can you see?
Excellent dissection.
Yes, yes.
So all cranial nerves and the facial, I didn't bother. Guru, mat chhil. Hey. This is my facial now, is in the covered in the fibrin glue. Anything more? This is about the various approaches.
Dr. Satish, Dr. Sayan is asking how management would have changed if frozen section would have come positive.
Yes, had frozen section would have come positive. Yeah, what I will do now, I will throw some remaining fibrin glue in the medial wall of the jugular valve. See this? Just remaining. We'll cover this cavity in a very different manner with a fat. Fat manner in the sense, we will put this entire cavity, we'll place the fat, and then I will place a large piece, see this, like this. Like this forceps. We will put a large piece like this in this tunnel. In this tunnel like this, and cover this tissue, suture this tissue to this, to separate the temporal bone from the neck again. This fat would be interposed, completely compressed in between the tissues on both sides. So that will segregate the temporal bone from the neck completely. Now coming to the question, what would have been the difference at this frozen section would come positive? So in case the frozen section come positive, I would convert it to a level 2, 3, 4, 5 comprehensive dissection. Okay, like this fat tissue, see this fat tissue, it will completely fill this gutter, and tissues on both sides will be sutured tightly over it to segregate from the neck after filling this temporal bone from above. Now coming to the difficult situation, I told you how to handle the difficult situations. First of all, Paramita, line up the questions. You told that you will take the question in the end.
Yes, sir.
Line up the question.
Good evening, Satish.
Yes, sir.
Mr. Morwani sir is here.
Yes, sir.
Welcome, sir.
Sir, welcome.
Satish, I just want to answer to say one point about what Paramita asked you. Have you ever given aneurysm? I have given aneurysm.
Yes.
Okay. And Satish has pointed out to you before, adventitia is very minimal on the horizontal portion. This was Ashim Desai's case I was doing, and I did a lot of bipolar cautery to get, I was too radical surgeon in that time, and I wanted to get rid of, Ashim was saying, please sir, there hardly any tumor left, and I did it, and this lady developed aneurysm. Of course, it was not of severe consequences, but she went through expenses of getting the coiling done at Just Look Hospital. This is about 12-15 years back. I've given it.
Okay, and Paramita,
sir, you are telling now you are not aggressive.
No, I'm not as aggressive as I used to be. With the time, you learn a lot of things. With the time, you learn a lot of things, Yeah, with time, you learn a lot of things.
Satish, actually, I never said that why you are doing this surgery. I never said this. My question is, it was like that, ki if we wait till 9, 10th, 11th, 11 now goes, or if intradural extension occurs, or it touches or encircles the carotid, so then we can wait by repeated imaging. What is the harm? This is my question. If we do like this, because the symptoms which patient develops now after this surgery, we can delay these symptoms for few more years. This is my question. Your take on this.
No, I'll answer this.
Deepak, we have already answered that.
Surgeon Glomus with you? Have you done any glomus surgery?
Yes, yes, about 10 we did, 10.
Okay,
10
and how many patients developed the deficit which was permanent and disabling? You answer the question.
Sir, why you want to listen from me, sir?
No, why not? But it's good to have feedback. It's good to have feedback.
Actually, sometimes even sometimes I feel why we did this surgery. Sometimes I felt like this.
Some patients you have to do even tracheostomy. They may have problem for 6 months, 9 months in deglutition. And I think more than 95% of them come around, the younger people, And as I said, I have to be more aggressive. If I see a tumor on Vegas now, for example, I will be not as aggressive as just now there's a tumor on the fascia now, for example. I would not be aggressive to go and bipolarize it today, If I can take out the sheet along with the tumor, I may, but I won't be as aggressive. So this is what time teaches you,
Hello?
Yes.
Hello?
But sir, one thing I want to say just on a lighter note, when you work, then you look more fresh. When you are sitting at home, now I am feeling this fatigue on your face.
Satish.
Yes, boss.
Yeah, people are asking you what is this fat and what from where you have taken and what antibiotic you have inserted.
How many people? Yeah, boss, I am coming to that. First of all, before we go to the last session of questions, to announce for the Sunday again,
yes,
those people who were not earlier, an extensive dissection demonstration on a fresh frozen cadaver from nose paranasal sinuses to the skull base, demonstrating each and every sinus, different approaches to the surrounding area, infratemporal fossa, pterygopalatine fossa, parapharyngeal space, skull base, detailed anatomy of the orbit, cavernous sinus, and various flaps, and extended and open approaches to the frontal sinus. This will be the theme to cover up the sinus part, because in the sinus part we have already covered the basic medical part, molecular level, decision making, then live surgical part, then radiology, and the cadaver is still remaining, which we'll cover in 2 sessions. So the first session will be on Sunday 11 o'clock. So you all are invited for that. Secondly,
if time permits, we'll go for head and neck also, neck flaps and
yes, that will show if you want in between. Secondly, the second part is some of the questions which have come here, which I am going through quickly to cover up in time. What to do with a very large size tumor, intradural tumor? Would you do same stage in any given situation? Yes. For tumors which are compressing the brainstem and giving pressure symptom, generally we don't do any tumor, intradural extension about 2 centimeters for the fear of CSF leak. Inability to control the CSF leak effectively. But in such large tumors with massive intradural extension, yes, we have done one case with a free flap we used and it worked well. But that idea of free flap with the cranial cavity open is not always good, because you have to give anticoagulant. But that worked well and a lot of people are doing it. Yes?
There's an alternative to this, where there's a large intracranial extension.
Yeah.
They have suggested doing the intracranial part of the tumor in the first stage and the extracranial at the second stage.
Okay. And before we move on further, Professor Magnan has been so kind enough to be with us for such a long time. And we are grateful to you, sir, for being with us. And
Dr. Satish, I am very pleased to see your surgery, and I would like to say to the audience, they saw an excellent surgeon today, really. Congratulations, and I am very pleased to be with my friend from India. I see Professor Marawani Narayam and the moderator. She was very nice, Paramita.
Thank you. But
thank you, sir.
You have done in your life, and we still think of learning more and more from you in future.
No. I learned a lot, and I enjoy this surgery, really. And I am very happy that you preserve the fascia nerve.
Thank you. And for the audience, Professor Magnan is one of the closest friend of Professor Mario Sana. They have grown up together since their childhood, and you can believe how close friends they are. So, Professor, convey our regards to the D. Mario Sana. I call him D. Mario Sana.
Sure.
Convey our heartfelt regards to him. And we hope to have him sometime for everyone here. We hope to have Professor Mario Sana sometime in future. And you are the only one. You are the only one who can bring him.
Professor Manion, Dr. Cassis from the COS clinic in France is wishing you, giving you regards.
Oh, yes.
Dr. Cassis from COS clinic.
He was a very good friend and a good pupil also. Thank you. Thank you to him.
Thank you, Professor.
Thank you, sir. Thank you.
Thank you.
Thank you.
Now the next question was extension to the cavernous sinus.
Satish, before he goes, you tell him to, Satish, before he goes, tell him to tell Jack Bunyan that he should be there for acoustic neuroma surgery and he should be moderating along. Request Jack Bunyan that when we are showing the acoustic neuroma surgery, let Mario Sana be there with us.
Yeah, I have already placed the request. Now we will move on further.
Okay.
Mario Sana.
Yes. Now the next question was what to do with extension to the cavernous sinus, foramen, magnum and clivus. I have already mentioned the extended approaches. This is the basic approach. Infratemporal fossa A is the basic approach, and according to the extension like clivus, I would go ahead with the transcochlear. For the foramen magnum, you will add on the far lateral approach. For the cavernous sinus, this is unresectable. You have to know your limits sometime, and cavernous sinus is something you cannot afford to take a risk of damaging carotid artery and the cranial nerves, and those are into the classified category of unresectable tumors for which radiation is reserved for growing tumors. The next is significant involvement and infiltration of the ICA. We have already discussed, and in the extreme condition which had led to narrowing of the artery, after the balloon occlusion test and cross-flow testing, if it is feasible, you can take a call of sacrificing, otherwise either stenting or take a conservative approach rather than doing a bypass or something else. Then involvement of the vertebral artery we have already discussed, dominant sigmoid sinus discussed, bilateral multiple paragangliomas we have already discussed. For that matter, it depends upon the status of the lower cranial nerves, which are more important than the carotid artery, which are obviously you are always preserving. So the call is taken according to that. And the another one is the recurrence after previous surgery, radiotherapy or stereotactic. So those are the most complex tumors. But yes, if they are growing and resectable, the surgery is the answer for that matter. Otherwise, to make them more inoperable if they grow further. So surgery is the final answer for those tumors in that situation, and the recurrent surgery or revision surgery, like any other situation in body anywhere, is most challenging. Anywhere in the body, the revision surgery is more challenging because of the fibrosis here, with the lost tissue planes around the carotid and the cranial nerves and the dura, can make the life so difficult you can imagine. Then the regions for the recurrence, there is a very good question regarding regions for the recurrence. I tell you, there are so many regions to the recurrence. As we started the tumor assessment at 4 o'clock, inadequate tumor assessment by imaging is the major cause of leaving the disease behind. The experience of the surgeon, of course, it matters how you deal with. Bleeding during the surgery, too much of bleeding during the surgery obscuring your anatomy is something inviting complication and leaving the disease behind. Then the facial nerve mobilization, if it is not adequate, like we were discussing about the facial bridge approach, the limited mobilization, in such situation of extensive carotid involvement, if you don't mobilize and try to go through a narrow window, that is something inviting a complication as well as residual disease. So inadequate exposure by means inadequate mobilization of the facial nerve is another reason. Inadequate management of the carotid artery, like we remove the tumor in the subadventitial plane. If you don't go so extensive and leave the tumor over it, is obviously you are leaving the disease behind. Then sometimes in the difficult areas around the carotid, like we drill to the petrous apex medial to the carotid. So medial to the carotid, lateral to the carotid, sometimes you may have to loop the carotid, mobilize it, and drill away the petrous apex bone underneath completely to take away the bone. And as I mentioned, that bone of the petrous bone, that cancellous bone of the petrous bone, where the tumor involvement is likely, if you don't drill completely, same thing is in angiofibroma. Next week we have a live case, angiofibroma, probably next Thursday, will show the major cause of the so-called recurrence is the tumor left behind, and that too in the pterygoid process cancellous bone. Same thing here, and you can pick up with a good pre-op MRI the cancellous bone involvement of the petrous bone by means of losing the fat signal of the marrow of the cancellous bone. If you do a fat suppressed sequencing where the fat is suppressed, if there is a tumor, you will find that enhancing, otherwise the marrow will show no signal in the fat suppressed sequences. So those are so many factors. If your tumor involving the medial wall of the jugular bulb, involving the lower cranial nerves, and you are leaving the tumor for the pre-op functioning nerves intact, you are leaving some part of the tumor that is inviting that sort of recurrence, if you see later on. So there are so many reasons to the question, to the recurrence. Paramita, you can take other questions. So many reasons to the recurrence in this tumor. This is a complex pathology. We know how deep we have to go, how you have to play with the carotid and the dura and so many neurovascular structures. So each and every structure has to be respected. Tumor extension to these each and every critical area has to be thoroughly assessed pre-operatively so that you don't leave any tumor behind. You can approach that tumor completely with confidence and having a 3D picture in mind that where all you are supposed to clear.
Few points, yeah.
Yes.
Big points are there regarding the obliteration, how you obliterated, and what was the material you obliterated the tube, and what was the footprint?
Okay, regarding the obliteration, I'll make few comments.
And any antibiotic?
Yes. So regarding the obliteration, our policy is first to obliterate the eustachian tube. We have already done a cul-de-sac closure. Then with the small pieces of fat in the narrow crevices everywhere to make flat, and then big piece of fat, that is overpacking, to completely cover the area as it regresses to some extent over the period of time. Then I said a longitudinal fat, segregating the temporal bone from the neck. Besides that, we use what would you say, rifampicin solution, where we dip our fat inside, keep there for half an hour or so, and then we use the fat in the place. We avoid using a vascularized muscle flap. A lot of people earlier would advocate a temporalist muscle flap. It is a vascularized flap. Vascularized flap is always better in that region. We never will rather condemn using vascularized flap. The reason is the post-operative follow-up is so difficult. Suppose these patients happen to recur the tumor after some time. In the fat packing, you can do a fat suppress MRI. You can suppress the entire fat and you can see the tumor only. But what happens if you are packed with a vascularized muscle flap? The muscle with the variable intensity of the fibrosis and the vascularity of the muscle, it will make your life difficult to differentiate tumor from the muscle. You cannot differentiate radiologically to the surety level the tumor from the muscle, and it is never a good prospect, and you are always in a fix whether there is a recurrence or not, and you cannot optimize those patient treatment. Nikalna question. Yeah.
So what about the post-operative complications? Can you just highlight quickly about?
Yes, the commonest is like we have already discussed, the cranial nerve palsy, the facial nerve to the grade 4 or so, it will come back to better. This case I am not very sure, the tumor infiltrated, and though we could preserve the nerve and transpose, but I am not very, the prospects are not very good in my gut feeling. then the CSF leak is a major complication if you have breached the dura. So in primary situation when the neck is in continuity, if the dural space is violated, you have to do everything to close the CSF leak. Otherwise, there is nothing to hold to your packing. What you have, because you have removed the skull base, the tympanic bone, and the fibrous tissue around it to hold anything from the neck side. So you have to be very judicious in closing the CSF leaks in multi-layer, and best is to use muscle pack and suture with the dura on both sides, sandwiching the muscle pack in between to give a tight pack. The muscle swells up and it really gives a good packing along with the glue and fat along with that.
Okay. So Dr. Utpal Jana from Kolkata is asking whether aortic capsule bone can be invaded by the tumor.
Yes, it was invaded. It was invaded. I had to drill a lot.
Yes,
That's what I was showing, that cancellous bone was involved.
So sir, do you believe in using Baha or cochlear implant in these cases?
Yes. For rehabilitation of the hearing, like in this patient, he has a severe mixed loss. Still Baha can be used, but in patients having a profound loss, with provided, I told you the basic functioning unit for the cochlear implant, provided the intact cochlea, which was not in this case, the capsule was invaded, we had to drill away. Intact cochlea and intact cochlear nerve is the prerequisite. If it is there, you can do the implant same stage. Or you can come back. See, we have obliterated the cavity. If the cochlea is intact and the cochlear nerve intact, you can come back afterwards any time, elevate the fat, do the open up the cochlea and insert your implant and replace the fat back and come out. Same thing in subtotal peterectomy for implantation. If you are not doing same stage, do everything, subtotal peterectomy, obliterate with the fat and everything. Then come back after some time, any time when your patient is ready, elevate the fat and push your implant underneath.
Dr. Umesh Tone from Nasik is asking, does partially open condylar vein or inferior petrosal sinus, can it cause air embolism?
Yes, it can. But you remember, we first ligated the internal jugular. So there is no question for air embolism. Yes. Otherwise it can lead to, and you have to be very quick to manage it, particularly put the patient in Trendelenburg position immediately to prevent further air embolism. There are questions like, lost the internet connection at 2 hours, want to see the recording, you can go to YouTube. It's always available, full unedited is available. Then can you always clearly identify the medial wall of the jugular bulb? Yes, unless it is grossly infiltrated. Then there is no distinction, and that you can pick up on radiology. If it is grossly infiltrated, means it is already intracranial extension. Then
how much facial nerve?
Any role of ferrocrilam to control bleeding in the surgery?
Yeah, a lot of people use that. Yeah, a lot of people inject the glue inside the tumor. We have never done. Narayan, any experience?
Nothing.
Yeah, a lot of people do that. I have never done. I don't know. That is, I believe, still not standard of care.
What is the facial nerve out of this case? Means how much are you expecting the loss? How much grade loss will be there, and after some time, how much time it will recover, up to what level?
It is likely to be grade 4, and in a proper transposition with periosteum intact everywhere, with not too much of stretching, you can get up to grade 2. Grade 2 is hardly any, I would say, paralysis to be obvious to the patient. And the best results, like Narayan said, if you do a resection anastomosis, the results in the best ends are grade 3.
So tell us about the management. How will you manage this case post-operatively? What will be your line of, what is the antibiotic, or what will you...
you have to give like any other. See, this has been purely extradural. You have not gone intradural. No major complication. We have segregated the neck, closed with the fat soaked in rifampicin. Just give an antibiotic for a few days and come out. You can discharge the patient day after.
Okay, sir.
Then the question is, inferior petrosal sinus, can you embolize? It's an amazing question. This inferior petrosal sinus you saw at the end of the surgery. It is such a source of bleeding you have witnessed. And I was quite conservative towards managing that bleeding. I was not very aggressively in packing the inferior petrosal sinus. Let it be in the end. So this bleeding is sometimes significant. And a lot of people have started embolization of the inferior petrosal sinus. It is not arterial embolization. It is the venous embolization which is very important. And sir, your nanavati department is supposed to be best in the country in embolization. Narayan, you have always told me.
Yeah,
We have never seen such good embolization here. But yes, inferior petrosal sinus, if embolized, it makes a difference. There are recent papers on a lot of inferior petrosal embolization I have gone through. The problem is the variable anatomy of the inferior petrosal sinus. Sometimes it doesn't open in the medial wall of the jugular bulb. Sometimes it open in the neck. Sometimes it open in the condylar vein, anterior condylar vein.
But the
Variable
most important, sir,
approach is difficult.
Satish, there can be 4 or 5 openings in the jugular vein.
Yes.
You can have 4 or 5 openings in the jugular vein.
Yes, yes.
That is important to get everything embolized. You need to be an excellent person, no? Satish, I'm taking your leave. All the best. Surgery was excellent and very well done. Narayan did a justice of that. All the best to all of you. Have fun.
Thank you, sir. We all are your students, sir.
You can put me off.
All credit goes to you.
Anyway, so you did a brilliant surgery. I'm sure Jack Manion he was not just saying for the name of the saying it, because he has not seen a surgery without embolization. He has seen all the time surgery with embolization. So it must be a change for him to see surgery without embolization.
This patient,
this patient, if at all, he doesn't require transfusion.
Yeah, we have not transfused. We have not transfused.
He doesn't require, if his hemoglobin was pre-op good. If it was bad, then probably one blood will be more than. It depends pre-op what was the hemoglobin, you know. If you start with 10 or 10, then this one did not require embolization.
Yes.
I saw your surgery almost 95%. So all the best to all of you.
Thank you, sir. Thank you.
Thank you,
You
sir.
put me off. Thank you.
Thank you, sir.
So, Paramita, any more questions?
Sir, I think we have covered almost all the questions, and I would like to say Dr. Nishi Gupta has written specifically for you that you are a magician, and I second on this, and I think everyone is of this opinion that you are really a magician. In this case, without an embolization,
this is just exchange of idea. This is a continuous process of learning from each other. We all are in the same boat of learning from each other. So thank you so much, and we can carry on this question later on, or you can text the question if you have any remaining, and hope to see you on Sunday with a different concept. The fresh frozen cadaver is a huge topic, huge subject, huge dissection. It's going to take long, and for any ENT surgeon, particularly the PGs, it's important to learn from the basics. Anatomy of the nose and paranasal sinuses, instrumentation and surgical approaches. And Narayan, thank you so much.
Thank you.
Narayan was wonderful.
Narayan is brother, and we are so grateful to him. For the next Sunday session, we are thrilled to have another champion faculty, international fame, Professor Prabhakaran Narayan from Malaysia. He's such a dear friend, such a humble man. One of the best human beings I have ever seen in my life. One of the dearest of the friends, and a dear friend of Narayan as well. And he has earned so much of name and fame in the endoscopy skull base in the entire world, and trained hundreds and hundreds of students across the world. Will be here with us to enlighten us on Sunday. So hope to see you in large numbers on Sunday. Thank you.
Deepak, any query, Deepak? You want to go?
Yes, I want to say that Dr. Nishi said rightly, Satish is a magician, and I can say about Narayan, he's so humble, and Narayan is also such a good teacher. I learned from him also. He was behind me when I was doing last Glomus, and he never he was not washed up, and he just guided me along the whole surgery. He is also an excellent teacher like Satish, And no doubt Satish is a magician. God bless him.
मेडिकल कॉलेज में है ना, मेडिकल कॉलेज में ना.
So can I say something?
Yeah.
Yes, yes.
There are so many people watching, maybe 5,500, 6,000, I don't know. I say in front of all these 5,500, 6,000. There are a lot of people doing fantastic work in India, but there can be only one Satish Jain. Okay?
Yes.
And I think it's unparalleled the way he does anything. Whether it's reading his scans, interpreting clinical data, surgical dissection. I think he is so beautifully with him. Satish, you were asking about embolization. I would not have been able to do this case without embolization as well as you did. So that's why I want embolization. So everyone would agree with one thing, that he's almost superhuman, and the tissues tend to respect him as much as he respects them. Satish, fantastic surgery, fantastic job.
Dr. Ravi from Muscat, he's saying again same word. Ravi, your side. Over.
Your connection is interrupted, I think.
There is a internet.
No, it's okay.
I think we are thankful to Sun Pharma for being with us, for believing us, for organizing the whole event for us. So we are really thankful.
Big thanks to Sun Pharma, and more than that, the mastermind, Dr. Rajiv Pachori.
Yes,
He
Dr.
needs a
Rajiv.
big applause because of his efforts, and I am committed to him.
Our team is good, I
and
think.
Dr. Rajiv Pachori and Paramita have done a wonderful job in organizing this. Thank you.
Once again from my side, sir, Mahendra Varman is here. Once again, my side. From my side, I would like to pay my sincere thanks, doctor. Very, very nice session today also. I mean, as usual.
Yeah,
thank you, sir.
smooth,
Thank you, doctor.
smooth and productive. Yeah.
Yeah, very productive. And Dr. Pratmita.
So we all are meeting on Sunday, 11 a.m.
Yes.
You said 10:30, sir? 10:30 or 11?
11. Our college has given us 11 o'clock.
Okay, sir. Okay.
College has given us the time 11 o'clock to start.
Okay.
They have some
Sir, thank you, sir.
ceremony in
Thank you,
the.
sir.
They have some ceremony in the morning. That's why I couldn't start 10 o'clock like last time.
Okay,
so
sir. Okay, sir.
We'll
Thank you,
start
sir.
sharp 11.
Okay, sir. Sure.
That will.
So, once again, sir, thank
Narayan-
you very much on behalf of
Narayan, hope to have you again on Sunday for your expert comments.
We're definitely watching you, sir.
Yeah, you'll be here with us.
Okay. Thank you. Thank you very much.
Thank you, sir.
Thank you, Dr.
Okay.
Narayan. Thank you.
Okay, Dr. Narayan. Thank you, Satish.
Thank you, sir.
Thank you.
Thank you.
Bye-bye.
Bye.